I am sure and I promise that today will be more exciting, more interesting, and more informative than yesterday. So, let's begin with the second day. I hope all you will enjoy. So, we are starting the first session, and I would like to call upon the stage the chairperson, Dr. G.L. Patel sir, and Dr. Paresh Majmudar sir. Please come on the stage. Dr. G.L. Patel sir is a practicing senior general surgeon in Bhavnagar. He is working in a private sector. He was IMA and GSSA member, life member, president IMA Bhavnagar 2004-5. He was also president of GSSA, and he is working since many years as a committee member of SWC and CWC. Dr. Paresh Majmudar sir is from Baroda, MD pediatrician. He has served as a President IMA GSB 2022. He is associated with Baroda branch. He was president and he has held so many positions in Baroda IMA, Joint Secretary, Honorary Secretary, Vice Secretary, Treasurer, and he is founder and current chairman of Hospital Board of India, Baroda chapter. He is trustee in Bailal Amin IMA Hall Trust since 2010. Now, the session is yours, sir. Chairman, sir.
Yes, we are starting with second day academic session, and the first speaker is of our own from Bhavnagar, Dr. Hardik Pankya. He is a well-known plastic surgeon, currently working as a plastic surgeon at Punit Nursing Home, Jail Road, Bhavnagar. He had worked with all major hospitals in Bhavnagar as a visiting plastic surgeon, specially interested in trauma and reconstruction, oncosurgical reconstruction, burns management, and aesthetic surgeries. He is a quite younger and dynamic person. We invite Dr. Hardik Pankya for his speech.
Hello, good morning to all. Actually had a heavy session yesterday and just starting in early morning. I hope the fun has served really good tea. So many thanks to all those dignitaries that are present here. Presenting early in the morning in such topic, it looks like, we all are cricket fans, so just like a night watchman in a test cricket. But yes, I would try to, not to fall back you again asleep with best what I can do. So basically, I'm here to talk about plastic surgeon, whether it's a necessity or a luxury, because our branch is more or less attached with many fancy things. So what actually we do, that's what I want to talk. Plastic surgeon, basically even my son get asked in a school that what your father do. Yes, definitely in a fancy way that we got answered that we do this fancy aesthetic procedures, even in a serial kind of way that we do a face transplant, but these are very fancy things and these are not done in a common setup. So very limited knowledge that what we do. Definitely in an emergency setup when we are called upon or when we do as a referral work, that's a completely different scenario. The other thing is that most of people here present that either they are neurosurgeon, so they deal with the kidney, cardiac vascular surgeon, they deal with the cardiac issues, vascular issues, as sir pediatrician, he deals with the pediatric ailments and general surgery, so more or less dealt with the GIT. But as a plastic surgeon, what organ specialty do you have if I am asked upon? I am not a dermatologist who deal with the skin if told upon. So yes, we don't have a very defined specialty, and many a time that gives us a hand over our regular thing that we deal with the whatever our special interest we develop and whatever our practice we try to lean on. So these are the few misconceptions, and many I think even I had been in Bhavnagar since last 1 year. So patient asked, Dr. Sahib, તમારા ભાવ થોડા વધારે છે, પ્લાસ્ટિક અમે લઈને આવીએ તો થોડું સસ્તું થશે. So yes, we don't use any plastic at all. Plastic is basically a Latin word which literally means that mold upon. So yes, just like government say, we also say no to plastic. Definitely same thing. The other thing, whenever patient comes to my OPD or my consultation, whenever I go to a hospital and they ask, well, doctor, would there be any scars? And the patient's expectation would be that there would be no scar or there would be minimal scar. But frankly speaking, we deal with the tissue like other surgeons do. We deal with a bit of delicacy, so there would be less scar, and that's the only thing we promise. But definitely we leave the scar. It would be lesser, say 80 to 90% lesser than the our larger sutures, because we would be using finer sutures. But the same thing could be achieved with the general surgical orthopedic practice where they use the finer suture. Other thing is that we are synonymous with the aesthetic procedures, cosmetic procedure. But yes, these are the 4 or 5 branch where we deal with the hand surgery, reconstructive surgery, trauma surgery, congenital defect anomaly, and then comes the cosmetic surgery where we commonly get attached with. Even in this town where I am practicing, my cosmetic practice would be hardly 10-20%, not more than that. Amongst them, I am only doing gynecomastia and hair transplant. That's it. Other than that, very few aesthetic procedures which I am doing, but these are the reconstructive procedure which we commonly get it done. Another thing is that it is very costly, definitely not cheaper, but the layman has this kind of conception because of the craze attached by this social media and many things, that it is quite a costly, not always thing. Entire face can be changed or iski tope uske sir kind of thing can be done. That's not a scenario. We cannot do it. Even in the world, there are I think 38 or 39 cases of face transplant has been reported. In Apex Institute in India, it is hardly I think 3 or 4 cases where face transplant has been attempted, and it is more or less right now indicated for large degree burns or major mutilation. For aesthetic things which we see in movies or series or something like that, it is not done for that purpose nowhere in the world. And yes, it is very risky procedure or media frightening is there, but yes, similar just like any surgeries, the similar surgical risk would be there. The another thing is that we need a better setup, better kind of equipments and everything. But yes, even in my alma mater Baroda and anywhere where the basic surgeries could be done, these procedures could be done. So basically dividing, we do 2 things, either it would be reconstructive procedure or it would be cosmetic things. These are the very long list of both procedures. What procedure I commonly perform here, that would be describing. So in reconstructive procedure, I actually came to here mainly with the, as I had a bit of attachment with the HCG. So cancer reconstruction, where we do free flaps, pedicle flaps and many things. Other is the head and neck trauma. The minor things like earlobe and nasal and plenty of reconstructive procedure. So it would be as simple as a simple basal cell carcinoma, excision, skin graft, or even with the lateral, the mobilization of the local flap, or it could be as complex as this one, where wide excision with the free fibula harvest, fibula putting in between with the coverage, and this free tissue attached with the neck vessel. Similarly, a neck malignancy, the lip malignancy, where the local tissue has been adjusted and consistency could be achieved. These are the cases where we mostly called upon in a surgical OPD or in orthopedic or even in the nursing home, where they would they expect a good suturing and the good results. So if done meticulously, these kind of results are generally expected, especially pediatric patients, especially females. These kind of results are expected. Similarly, assault, CLW, same patient with the 3 months, they do have some scar, as I initially mentioned, but they would be less conspicuous, as it would be sutured roughly. This, if we go one step higher, then again a very large defect on the forehead, where initially I put the full thickness graft. Patient came again, she had a eyebrow loss, so hair grafting, and at the end it would be good. Very common or very huge bulk here is the where surgeon sees the patient like this. Initial debridement with the proper cleaning, wound improves and grafting. This is the one of the commonest cases we commonly do. These are the very simple looking wound, but if done properly with the meticulous suturing, it gives reasonable results. These are the keloids, very common ailments. Definitely I don't exercise at all, but local steroids, 5-FU or even very resistant cases, I go with the low dose radiotherapy. It gives the consistent result with the resolution or staying it, aesthetic concern, which used to be patient with the previous things. Another bulk which I commonly do is the facial injuries. All facial bone can be repaired timely if approach. I commonly do this procedure with the either neurosurgical team, maxillofacial team, where could be a maxilla, zygoma, mandible, or the floor of orbit. These are the things. The major bulk forms in emergency practice is the hand surgery, where simple hand tip injuries which can be managed with the local flaps, with the flaps from the adjacent fingers, and then it can give a reasonable good results. And patient would be, especially this class is more or less working class, so more they had a main concern is return to work. So most of these patients return to work within a month. Again, if the contact burn or the crush kind of injury where the nerves has been damaged or the crush is there, so this thing can be achieved. We can go a bit higher where clear-cut amputation is advised. Yes, definitely this hand doesn't look good, but it is better than nothing. So patient would have his or her hand, and in the later stage, this is the recent cases, so I would do a separation after 6 months. These are the few of the things which we take very proud in it, but frankly speaking, results are not more than 30 to 40%. This is classical case of replantation. Yes, we usually present this in all the presentations, conferences, but these are the results where we, to be honest, where we were lucky and we got it right. Many of these definitely got blackened out, but definitely we should try. If patient has the money is not the issue and or the corporate things is there, then we definitely can achieve the result. The time window is on an average 6 hours. More than that, it would not be possible. The same thumb replant definitely survived. This is the common thing when we called upon by the referring doctor. Simply wash out with the whatever solution you do have. Tap water would be more than enough. Wrap in a handkerchief if you have, or the patient relative's handkerchief. Wrap it up, put it in a plastic bag. We do have plenty of plastic around us, and put it in the eyes, that bag in the eyes, not directly put the finger in eyes, otherwise it would be thorn within 2 to 3 hours and the finger would be no use to me and I would definitely discard it. Again, the more degloving kind of injuries and we can treat it. The chronic deformities, boutonnières, this could be done. Similarly, even simple looking wound, but exploring it, we can prevent the catastrophe of losing the limb, and the positibial artery and nerves are repaired. The burns forms the one of the larger part in plastic surgical practice. As GL sir is there, he is doing excellent practice in burns. So whenever large area is there, as a plastic surgeon, our help is sought, and we either do grafting, flap, whatever things are required. In pediatric, we had more or less shift toward the collagen application because of as the burns more or less is not deep in pediatrics. Mostly, as we notice, it is either of some kind of scald. Either it would be hot water or oil or whatever, maybe in the firecrackers. So the main issue in the pediatric burns is that the issue with dressing. So we put collagen, it would heal with the as shortly as possible within 7 to 10 days, and patient would be free from his long dressing related pain. The same thing with the burn deformities. Patient would have enormous deformity starting from the fingertip to the eyes, neck, axilla, elbow, and all deformities can be corrected timely. Again, as we pediatricians are here, so these are the few pediatric anomalies. In my residency days, these used to be high volume, but frankly speaking, in 3 years private, cleft because of high availability of smile train. These clefts are more or less very minimal in the private scenario. Again, the hand anomaly, the extra finger or polydactyly or the macrodactyly, this could be corrected. Again, ear anomalies are enormous, from the anotia to the prominent ears to the microtia or the traumatic anomalies, these all can be corrected. And the hypospadiasis, as we all know, it forms a very common pediatric anomaly, could be corrected in a stage. The chest anomalies, again, the keloids and very resistant form that could be corrected. This is very aggressive case where dermatofibrosarcoma was there, and it was widely excised anterolateral thigh, harvested, attached with the left side vessels. Pyeloneal sinus and pressure source, this forms the common basis. Again, the neurosurgical team has drained the epidural abscess, axillary things. These are, even we go a step higher, where if this patient are seen as many of the orthopedic or general surgeon are there, definitely amputation is the primary advice. But if patient want to go with whatever salvage he or she can have, we can do something like that, put in a muscle flap, that is the latissimus dorsi is kept, and then the skin graft is kept. Again, the same thing, rollover accident over the limb, and the vessel was continued with the anterolateral thigh flap, it was the flow through flap. The same thing with the minor scar revision, it could be very minor as in the first two images, or it could be very drastic in the last two images. The last few things is the diabetic foot surgery. Again, it forms the major crux, and it could be very limited to the very advanced foot surgery. The last 2-3 things in the reconstructive portion is the vascular malformation, trismus, or the fistula creation, or ingrowing toenails. The cosmetic things I would be talking in very brief. So among my practice, I do most commonly is the gynecomastia. I don't know the reason exactly, frankly speaking, but even in the many of articles says that it is 3 in 1 male is suffering from that. If patient has an issue, then and then we should operate it. Even in the adolescent up to 18 years, it is not advisable. So classical in lateral view, you can see that patient would have an embracement, and we do liposuction with the gland removal. So there would be no to minimal scar, and it would be daycare procedure. So patient would be gone home by evening and resume his work after a week. Heavy work would not be advisable for 3 to 4 weeks. Again, the rhinoplasty, the old nose injury, we can put it on a straight. Definitely nose is the one of the thing that which make the most important facial feature. So rhinoplasty gives the excellent facial outcome change if we wish to have. The similar results, consistent results can be achieved. These are the postpartum abdominoplasties, not commonly done here in Bhavnagar, but yes, these are the things where we can achieve. This is not my patient, so high definition liposculpturing could be done. This was there where I was doing my fellowship. The another thing is the breast surgery, where we as a plastic surgeon that we do breast augmentation very much. Frankly speaking, in my 3 years of private practice, I had done hardly 4 or 5 cases. The another surprising thing is that reduction breast patient came for very commonly for reduction. These are not aesthetic patients, they are more or less patient with the back pain. They had consulted all neurosurgeon in the town, consulted all senior orthopedic surgeon in the town, and the back pain was not actually from this pain, the spine, but it was because of heavy weight which was causing the referred pain in the back. So these are the multiparous, maybe 45-50 a female, and we do reduction in those patients. These are the my 4 or 5 patients I just mentioned. Augmentation, it give reasonably good result, but yes, frankly speaking, half-life is only 10 years. The burst and everything which you see in media, it is not that common except for the trauma or RTA. And after 10 years, even in the wrapper, it has mentioned that we should replace it with the new implant. So implant life is only 10 years. But yes, the patient mostly expect 1 or 2 replacement, and then it would be the adolescent or the later phase, younger phase. After 40, they mostly don't expect us to change in our setup. In Western world, they definitely doing it. This was the reduction I was talking about. We do wide resection and huge reduction is achieved. Even in my, I had done not very large number, but 15, 16 patients, hardly 1 or 2 patients had not requested me to reduce more. This is that much common, that patient expect whatever you can remove, doctor, do it as much as you can. The arm lip brachoplasty, where these are the post-bariatric patients, where we can achieve this result. Again, this is from my fellowship training. And the hair, definitely along with the dermatologist and even in the other people, we give definitely good results. The fat grafting and dimple creation, more or less this fat grafting has the idiopathic lipodystrophy. So these kind of patients are there where their main concern is not the aesthetic issue, but they had a very huge the depression. More or less it is from where their pediatric age, but as they cross the adolescent, this is the one of the the fancy thing where people get very fascinated. So it's not that much the large procedure. It is done under local anesthesia. The downtime is hardly within 1 or 2 days. But yes, if patient feels that that is the dimple which make she or he look pretty, then that's it. The lip reduction procedure, in our especially darker people, we do have a the large volume of lip, so we can do such procedure. Again, the Botox and fillers. So yes, as we do, there may be a volume deficit or the classical wrinkles, so we can tackle it down with all of them. These are the few of the last thing. Amongst them, I regularly got to do is the vitiligo surgery, where the dermat people had done a very conservative thing, and that is the last sort, where I harvest a very thin graft and put it over it. It gives more than satisfactory results. The other two things, even everybody had read it in a news that government is trying to take it in a yojana and everything, is the gender reassignment. I usually do it with a urosurgeon, and frankly speaking, it is not my expertise as of now, but I think that is future, we don't know, because this is the trend and it should be followed with the years. So these are the things. These most of cases are mine. Few are imported from for the technical or the educational purpose. Thank you. Thanks a lot.
Thank you, Hardik bhai. Very nicely elaborated, and we have finished it in time also. According to your speech, we would conclude that plastic surgery is a necessity and it is not a luxury.
Thank you, sir. Thank you. Thanks, sir.
No, I would say for patient it is luxury always, because when the name plastic surgery comes, patient always asks that if we don't go for the plastic surgery, then so for patient it is luxury, but for us it is a necessity.
Yes. Thank you. Thanks a lot, sir.
In a reconstruction field, plastic surgery gives a very good result, free flap, and in the oncological reconstruction, and
Yes.
so it's a better opportunity in the future also.
Yes, sir. Thank you. Thanks a lot, sir.
Hardik bhai,
Yes, sir.
question to you.
Yes, sir.
Usually you have shown several conditions in pediatrics.
Yes, sir.
So what kind of anesthesia you use for this procedure?
Sir, most of time it is general anesthesia.
Almost.
Almost,
Any-
except for where hypospadiasis is this, where they do give a caudal block plus sedation. But in hypospadiasis, what I notice is when patient is, the post-op phase, there would be erection.
Okay.
So the erection is very dangerous to me because of erection, my suture would be burst out. Okay. So most of the time I expect pediatric fitness followed by general anesthesia only, sir.
Fine.
Yes. Thanks.
Are you dealing with gynec cosmetic surgery particularly?
Yes,
Sir, I am doing vaginoplasty in RMKH syndrome. That is one thing. The labial reductions I had done few. These are not my, I am not doing the PRP or the fat grafting in those area regularly. Hymenoplasty, as I used to practice previously in the Surat. So I had done at least five cases of hymenoplasty 4 weeks before marriage, and no sexual activity is advised in those periods. It is done under sedation, where patient walks in your OPD. But we definitely need to have some hymen flaps, so we can close it with the Vicryl 40. Amongst 4, I had follow-up of 2 patients where she had a normal kind of, and she could conceal her the lost virginity, which was from the previous event. She want to conceal it from her new partner. So that was the thing which I commonly do in the gynec. Most of my gynec patients are either for breast or for abdomen, where they had done 3 or 4 deliveries. So this patient comes that anything doctor could be done for my hanging pendulous or this back pain, so they send it for that. Thank you.
Thank you, sir. Now I request chairperson, sir, please honor the speaker with the memento. Dr. Sanjay Samani, sir, to please come on the stage and honor the both chairpersons.
થેન્ક યુ સર, થેન્ક્સ અ લોટ. તમને નામથી સર સારી રીતે ઓળખતા રહ્યા પણ બીજી ટાઈમ.
Thank you, Dr. G.L. Patel, sir, Paresh Majmudar, sir, and Dr. Hardik Bhai.
Moving on to the next session, I request Dr. Naresh Gohil sir and Dr. Bijal Kapadia to chair the session. Dr. Naresh Gohil is a consultant neonatologist and pediatrician practicing since '94 in Bhavnagar. He is pioneer of NICU setup in Bhavnagar. His areas of interest are neonatology, pediatric respiratory medicine and vaccination. He has been a founder secretary of IAP Bhavnagar and has been a president for IAP Bhavnagar from 2008 in 2008 and 9, and he was executive board member of IAP Gujarat State Branch and published many papers in national journals. Dr. Bijal is a vice president of IMA Gujarat State Branch of South Zone from 22 to 24. Vice President of Daman Medical Association, State President Dr. Sel, Dadra and Nagar Haveli and Daman and Diu, and he is also NABHSSR. I request chairpersons to take over, sir.
Thank you. Good morning, everyone. Dr. Ambika Gupta is the speaker for the second lecture. She has done her MBBS from Government Medical College, Baroda, MD Pediatrics from King George Medical College, Lucknow, DM Medical Genetics from AIMS, New Delhi. She has also done her certificate course in cancer genetics from UK. She is affiliated as a consultant medical geneticist with Apollo Hospital, Ahmedabad, and Apollo Health and Lifecare Limited, Delhi. She has a special interest in assessment, diagnosis, and management of rare disorders, prenatal genetics, inborn errors of metabolism, dysmorphology, and neurodevelopmental syndromes, familial cancer syndromes, and molecular oncology. She has received several awards from the Indian Academy of Pediatrics, Indian Journal of Pediatrics, and ICMR, including the Best DM Thesis Award. She has original articles and case reports in various journals. She is editor-in-chief of the Apollo Genomics newsletter. I welcome you, madam, and please take over.
Good morning, everyone, and thank you for that warm welcome and that elaborate introduction. Thank you so much, sir, for that. And I also thank the organizers of the conference and Apollo Hospitals for vesting their interest in genetics. And through this talk, my only purpose is to prime you all to the basics of genetics, like when we should start suspecting a genetic disorder. So I hope it will be, I've tried to keep it simple, but yes, do excuse me, and I would want to seek your pardon for my bad throat, so that may be a problem little bit in the duration of the talk. And of course, I'm open to discussion after the session ends. Yeah, thank you. So meanwhile, while they are fixing it, I would also like to tell you that at Apollo Ahmedabad, so it's me, and with me, I have my beautiful genetic counselor, Mrs. Reena Trivedi. So we are a team at Apollo Genomics Institutes, and many of you might be knowing her already. So Reena, if you can just stand up. And okay, so how many of us know this great personality? So going back to class 12 biology, he is the Australian monk, Mr. Gregor Mendel. So we used to read 3 laws of genetics: the law of dominance, the law of independent assortment, and the law of segregation. So all these laws came from this great man, and he laid the foundation of human genetics. And we today are reaping the fruits of this genetics in the form of the COVID vaccine, which all of us have taken, I guess. And this comes from a mRNA, that is a messenger RNA modification. And this year's Nobel Prize went to Dr. Wiesman and Dr. Carrico for designing the mRNA COVID vaccine. So until 2-3 decades ago, all we knew was Down syndrome or trisomy 21. As we can see in that small insert, this small child. And it all began with the staining of the chromosomes. So This was in 1970s. So what you see here in this purple shaded area, so each of these is a chromosome, and this is very clearly visible under a phase contrast microscope. And then later on, as the Human Genome Project started, and it got completed in 2003. So that was the dawn of modern human genetics. Well, the question is that in our busy studies, like when we are doing our MBBS or even when we are doing our post-graduation, we really do not have time to rise up above the common disorders, and there is so much to read. So the question is, when should we be suspecting a genetic disorder? So I have tried to simplify that in the form of some handles which will help us decide when to think and when to send a testing for a genetic disorder. So the first handle is a family tree, that is a pedigree, which as students we are taught, but in a busy OPD practice, we sometimes miss on some vital information that is available through a pedigree. So if we look at this pedigree, then we see that only the males are affected, and before each and every affected male, there is a normal female. Here, I hope I'm able to show you this, and even here. And we see that there is no male-to-male transmission. So these are characteristic features of an X-linked recessive disorder. This is a classical family history of Queen Victoria, who has this hemophilia in her family. So what I'm trying to say is that we should just not stop at the couple and the children. We should go at least 2 generations higher. So preferably a 3 to 4 generation history, especially when you are suspicious of such type of a disorder. And the pedigree also helps us in deciding the mode of inheritance, whether it's autosomal recessive, dominant, or X-linked recessive. And it's also important to note that a negative family history does not rule out a genetic condition. Many, in fact, most of the genetic disorders will be arising de novo. So just an example, this was a lady, This was a lady, 25 years of age, who came to me with a history of malignancy of breast in her mother at 45 years of age. And this lady died with cancer. She also had a maternal uncle, Mamaji, who died of carcinoma of the prostate at 65 years of age. And there were other disorders running in the family. So her concern was, am I at risk of malignancy? And what I'm going to do about it? So luckily we had sample of the mother, the blood sample. So we extracted the DNA and we did testing for some of the cancer predisposing genes. So luckily we got, luckily or rather unluckily, we got a mutation that is disease causing or cancer causing in the BRCA2, that is the BRCA2 gene. And the same mutation was also identified in this girl. So now what are the implications? Why do we even need to test? It's because this is a cancer predisposing gene, and somebody who carries a BRCA2 positive gene, being a lady, she is at risk of getting carcinoma of the breast, which is up to 84% in her lifetime. And many of these will be before 50 years of age. And it's not just males, it's not just the females, males are also at risk, especially of CA prostate, as high as up to 25% lifetime risk. So the utility goes that we can put them under surveillance so that even if they develop cancer, it would be a very pre-cancerous type of a lesion, and then it can be taken care of better. The other is they can go for a prophylactic mastectomy or salpingo-oophorectomy to prevent the development of CA breast or CA ovary, as happens with this particular gene. Third is therapeutic implications for the patient itself. So if the patient is alive, he's more amenable to platins, he's more amenable to a new drug, which is the PARP inhibitors, and they are routinely being used now, although they are a little expensive. The second handle is the age of the disorder right? So this was a young girl young lady rather, 23 years of age, who came with end-stage renal disease and had to go for a renal transplant at 27 years of age. And she was diagnosed as IgA nephropathy. Her brother also had a milder form of the disease with mild hearing loss, and he was also diagnosed as IgA nephropathy. And the patient wasn't worked up, they were just on a conservative therapy. So when this man got married and the wife became pregnant, she was worried, could my child also be having this type of disorder? So then the obstetrician referred the patient to us, And we suspected, because there was hearing impairment as well as the renal involvement, we thought it could be Alport syndrome, and we tested for it and it came out to be positive. Now the implications were that this fetus was tested in utero, and when it was sure that he doesn't have Alport, then the baby, healthy baby, was delivered. And Alport's has a good prognosis with a nicely done renal transplant. So prognostication, and this particular lady, now she's planning a pregnancy for herself. So we know that we can give her many reproductive options to have a healthy baby. So if we go according to the age, then if you have a renal failure patient who is less than 30 years of age, you should suspect a genetic disorder, because around 10 to 15% adult patients with chronic renal failure will have an underlying genetic etiology. Similarly, if you have a history of sudden early cardiac death in the family, especially less than 40 years of age, you should suspect inherited arrhythmia or cardiomyopathy. And 30% of sudden cardiac deaths are due to an underlying genetic etiology. Similarly, if you have malignancy at less than 50 years of age, just don't take it as a normal malignancy. Do take a broad history. Do evaluate yourself for possibility of a familial cancer syndrome, because it has implications for your all first degree relatives, your brothers, sisters, your children, everybody. Especially if you have coronary artery disease. So if it's at an age less than 30 and you have a family history, so there is always a possibility of an underlying genetic disorder, for example, Fabry's disease, familial hypercholesterolemia, or homocystinemia, just to name a few. So the third handle is the severity of this particular disease in my patient appropriate? So I'll just tell it with the help of an example. This was a 15-year-old male child, poor weight gain, poor growth, born to non-consanguineous parents. He came with complaint of severe cough, sputum production and hemoptysis, and on top of that he had acute onset respiratory distress. Now on taking his history, he told that since 3 years of age he's been having such type of episodes, but not so severe. And at age of 14 years, he unluckily had a pancreatic involvement in the form of diabetes mellitus. His CT scan chest was suggestive of bilateral bronchiectasis, as we can see. So we thought that all the involvement of the pancreas, bronchiectasis, this is going in favor of cystic fibrosis, although most of the cystic fibrosis patients would be diagnosed in a relatively early age. But then depending upon the mutations, things do change. So we did a screening test with sweat chloride, which was high, more than 60 millimoles per liter. And then we did a whole exome sequencing, which is one of the most standard tests for genetic testing. And we proved that this patient had cystic fibrosis. So thereafter, he was put on a proper cystic fibrosis management guideline. So the next handle is, does my patient look weird? So this has several components. I have made this in the form of an acronym, and I hope it will help you remember. So W stands for whole body involvement. So is multi-system involvement there in my patient? Are the investigations inconclusive? So I stands for investigations. E stands for explained. So is the disease not explained by TIMA? So TIMA stands for trauma, infection, malignancy, and autoimmune, which are the common etiologies of our usual disorders that we see. Is the growth retarded? And is my child or my patient dysmorphic? So whole body system or multi-system involvement, this is one of the biggest clues. So we had a patient, 4 years old. He came with progressive abdominal distension for since 2 years of age, along with recurrent episodes of breathlessness requiring oxygen. He had short stature and failure to thrive. On his examination, he had micronodular infiltrates in the chest X-ray. In the eye examination, his fundus showed a cherry red spot, and he also had hyperlipidemia. So we had the reticuloendothelial system affected, the respiratory system affected, and the eye involvement. So all these were clues which fit together as a pieces of a puzzle, told us that this could be Niemann-Pick's disease type B, which is a lysosomal storage disorder. And we tested this patient for enzyme acid phengylamylinase, which was deficient, which proved the diagnosis. We can also go for mutation testing in such cases. So next is when your investigations are inconclusive. So this 18-month-old female presented with rachitic features, as we can see. There is widening of the wrist, there is bowing of the knees. And on his examination, he had mild hypophosphatemia. He had normal serum calcium levels, low to normal activated vitamin D levels, and normal circulating, the 25 hydroxy vitamin D, which we usually measure, and a very high serum alkaline phosphatase. So he was treated as nutritional rickets for 1 year, but then he didn't get any relief. So then the patient was referred to the endocrinologist and the geneticist. And seeing this whole condition, although he didn't have frank hypophosphatemia, but we knew that, okay, this is not responding to the vitamin D, so it's vitamin D non-responsive. We had a slight suspicion of an X-linked hypophosphatemic rickets, and so we tested, and this patient came positive for a FEX gene mutation. So the treatment is different for this particular type of rickets. We need to give phosphorus. We also need to give activated vitamin D, which was started in this patient, and there was around, like we can say, 50% resolution within a period of 6-7 months. He's still continuing, and it will take time for him to recover. The next handle is if your patient's condition is not explained by trauma. So if you have 1 fracture, 2 fracture, traumatic, it's fine. But if you have 5 fractures, then they just cannot be explained by simple trauma. So in that condition, you should start thinking of something like osteogenesis imperfecta or a metabolic bone disease. Similarly, if somebody is having recurrent infections or very atypical infections, severe or prolonged protracted illness course, then we should excuse me, we should start thinking of primary immunodeficiency, and majority of them are single gene disorders. Similarly, malignancy. If you have multiple malignancies or malignancy associated with something else, then we should think of familial cancer syndrome. For example, colon and endometrium, if both are involved, it is suggestive of Lynch syndrome. And next, like autoimmune. So a lot of adult onset disorders have an autoimmune etiology, but if you have something additional with it, for example, if you have diabetes, along with it you have some ocular involvement, it could be a mitochondrial disorder. So now retarded growth and development. When I mean growth, I am more focused on the height of the patient, stature and its proportion. So when it is, you have short stature or severe short stature, which is below -3 standard deviations for age, and this is not explained by nutritional deficiencies, familial or constitutional short stature, then it is more likely to be genetic in etiology. If there is some disproportion, it is more likely to be a skeletal dysplasia, especially if you have some form of bony involvement, skeletal involvement, or it could be other short stature syndromes. For example, as simple as Turner syndrome, Noonan syndrome, or many chromosomal syndromes. So one should always get a full body skeletal survey. Majority of the cases would be solved by simply getting an X-ray of different parts of the body. Now developmental retardation. So many of the metabolic disorders and neurodevelopmental disorders, they do mimic as autism, cerebral palsy, birth asphyxia, seizure disorder. And many of these patients go unlabeled and they are just on symptomatic treatment. And then they have, other siblings also affected with similar disorder. So one should always look for clues like, was the birth history normal? And it cannot be birth asphyxia. Is there neuroregression or multi-system involvement again? So this way we can get clues towards a genetic etiology. And now coming to the most fun part, interesting part of genetics, that is, solving the puzzle by looking at the face, decoding the dysmorphism, which means that any part of the body may be formed in an abnormal way. That is like dysmorphism. So what I wanted to show you here is the facial aspect of it. So we see, like this is a patient of Down syndrome, so you can appreciate this up-slanting palpebral fissure, which is so characteristic. Then this small mouth with protruding tongue. So these are classical. In this particular, yeah, it's okay. So you see the eyebrows are relatively absolutely straight. So this is very characteristic of chromosome 1p36 microdeletion syndrome. So you don't need anything else, you just then need to confirm the diagnosis. You see a tube-like nose here. So this is very characteristic of the velocardiofacial or the 22q microdeletion syndrome, which is the most common chromosomal microdeletion syndrome. Then if you look at these hair, these are like kinky here and this peculiar color. So this is very much likely to be Menkes disease, which is a neurodevelopmental disorder associated with copper metabolism. And if you see this perioral coarseness, and you see the skull, then you can spot diagnosis. This is most likely a case of mucopolysaccharidosis. Similarly, if you see a very wide mouth and separated teeth with chubby cheeks, you know that this is Williams syndrome. So dysmorphism per se is not limited just to the face. They can be different other parts of the body. Sorry for that. For example, if you have a child with thrombocytopenia, along with that there is absent radius, then it is likely to be thrombocytopenia absent radius syndrome. Similarly, if you have a child with seizures or an adult with seizures for that matter and has these facial characteristics called angiofibromas, and he also has this hypopigmented streaks like Ashley macules or shagreen patches, then he is likely to be tuberous sclerosis. Then this third figure, if you can appreciate, there is a difference in the color of the iris. So this is called heterochromia iridis, and he has a white forelock. So this is suggestive of one of the most common autosomal dominant hearing impairment syndromes, which is called Waardenburg syndrome. So just a word on rare diseases. So we know that most of the genetic disorders are rare, and there are a few non-genetic rare disorders. So they are up to like now 7,000 to 8,000 rare disorders, and it's not that rare. If you collectively see them, then 1 in every 17 patients is having some form of rare disorder, and 80% of the rare disorders are genetic in etiology. More so, maximum, at least 50% of them are occurring in the pediatric population, and unluckily they remain undiagnosed for a couple of years, and we lose that period where we could make some active intervention. So the take home message from here is that genetics is easy, but yes, you need a lot of patience, you need a lot of practice and experience. Foremost is to know when to suspect a genetic disorder. So one should ask these questions, as I said, is the pedigree suggestive, is the age unusual, is the severity inappropriate, and does my patient look weird? So I would like to end with this small collage with me and Reena, our team at Apollo Genomics Institutes. So it's good to be a part of the conference, and I am happy to take any questions. Thank you.
Thank you, madam. It was an excellent presentation.
Yeah. Sir, just can you just give me 1 minute? I would like Reena to speak just 2 words upon genetic counseling.
So, thank you very much, Dr. Ambika. So, we have seized this opportunity to educate our audience about what genetic counseling is. Genetic counseling is a very new profession, and it includes genetic counselors who are qualified to identify genetic disorders, and they work in collaboration with doctors. We at Apollo have a very dedicated team of me as the genetic counselor and Dr. Ambika, and we try and identify patients with genetic disorders, help them. We even help them get free treatment, sometimes free testing. So genetic counseling involves educating the parents about how they can reduce the risk of having further children with genetic disorders. Also risk assessment of others in the family, other family members who might have these type of genetic disorders. So through communication, we help identify the rare diseases, and we help the entire family through the counseling process. And at Apollo, we are going to be launching our Institute of Genomics in the month of December. And I take this platform to introduce all of you and welcome all of you for the launch ceremony in December and make use of our services.
Thank you, madam.
Thank you so much.
Thank you, Reena.
It was an excellent presentation, madam. All these years we thought that role of geneticist is more in diagnosis and prevention. The role in treatment part is still minimal. Is it still true? And something on newborn screening.
Yeah. So, sir, answer to the first part is that if we see, I mean, if you are looking for the treatment of, for that matter, any disorder, I would like to say that it's only the infectious diseases which you are able to treat 100%. The rest is about maintaining the patient. For example, if you have diabetes, you can't cure it. If you have hypertension, you can't cure it. You have to have some sort of medication throughout your life. But what genetics does is, yes, a lot of genetic disorders are now having treatments, and there are now more than 30 FDA approved therapies, and many of our children in India, especially those with lysosomal storage disorders, are now able to receive. So genetics is now actually taking its exponential direction. So Government of India has also come up with this rare disease policy. So in this policy, they are now, like the government is ready to give around 50 lakh rupees as a one-time aid as of now for all those patients who are diagnosed with a rare disorder. With this, I would like to say many of the metabolic disorders, the what we call the inborn errors of metabolism. So many of them are manageable if they are diagnosed early. The most important thing is to diagnose them early, because if there is a neurological damage, you're gone. I mean, you can improve the quality of life, but then intact neurological involvement is what we are after. So if you diagnose early, and for that matter, newborn screening has a lot of role to play, then we can put them on a specific dietary therapy. And as the child grows, initially the dietary therapies will be more stringent, but as the child grows and he starts eating the normal foods and he gets a sense of his disorder, then things are relatively easy. For that matter, glycogen storage disorders or a lot of mitochondrial disorders, fatty acid disorders, you just need to maintain the blood sugars. You do not want the child to run in hypoglycemia. That's the only treatment. So that can easily be managed with even home-based diets. And now a lot of therapies are available in India, and it's going to grow, sir. Yes. And newborn screening, like the government, I do not know personally about the Gujarat state, but in Delhi at least we are now screening each and every newborn child who is born within the state of Delhi for at least congenital hypothyroidism, congenital adrenal hyperplasia, then also for hemoglobinopathies and visible birth defects and heart defects, yes. So screening does have a role, sir.
Okay, thank you very much, madam, for a very informative and useful approach in a genetic disease, particularly in a newborn and pediatric patients, where we have a disproportionate finding, unexplained deaths in our NICU and PICU. We have to take help of the genetic study, and we have to be helpful to the parents in subsequent pregnancy also. Thank you, madam, please.
Thank you
very much.
Thank you, Suchak sir. Thank you, Naresh sir and Bijan sir.
As now minimalism is becoming more and more popular, so we are proceeding towards minimal invasive cardiac surgery. And to chair the session, I would like to call upon stage Dr. Vijayaraj Gohil, sir, and Dr. Parth Waghela, sir. Please come on the stage. Vijayaraj Gohil, sir, is a practicing surgical gastroenterologist. He is the director and head of the GI and Bariatric Surgery Department, BIMS Multi-Speciality Hospital, Bhavnagar. And he is visiting International Surgeon, Asia Cryo-Bariatric Metabolic Surgery Center, Beijing, China. Parth Waghela is a young, enthusiastic, practicing cardiothoracic vascular surgeon since 5 years in Bhavnagar. His special interests are adult congenital cardiac surgery, coronary artery bypass surgery, valve replacement, and minimal invasive cardiac surgery, and almost all the areas of cardiovascular surgery. Now I hand over the session to chairperson.
Good morning, everybody. I would like to represent Dr. Sudhir Adalati, sir, who is senior consultant cardiothoracic and vascular surgeon, and he is expert in minimal invasive cardiac surgery as well. He has done fellowship from Auckland, and he was previously associated with UN Mehta as a associate professor. Sir is senior consultant in CTVS department at Apollo in Ahmedabad and Bombay, and he is working in as a CTVS since last 20 years. And he has many national and international publications, and he has developed his own novel method of left atrial reduction with giant left atrial reduction with right atrial reduction also.
Thank you very much, Parth and Dr. Gohil, for such an elaborate introduction. And before I start, I would like to thank the organizers for giving me an opportunity, and also the Apollo Hospitals, or a group of hospitals where I work, for having me present this presentation, which is very close to my heart. I've been practicing minimally invasive cardiac surgery since last 10 years now, and I must confess that it is a very rewarding technique, and especially when you watch your patients after surgery. Before surgery, yes, most patients have their doubts, including me in my initial years, whether I would be able to do or deliver justice and as good quality surgery as is done in open. But that doubts and those suspicions, they have all settled as the time has gone by, and so have my patients, which have rested their confidence in me. So proceeding from such an enriching genetic presentation to which is a causative presentation to treatment part of it, that is the cardiovascular surgery. So I'll be talking about minimally invasive cardiac surgery at brief perspective as to what we have done and what we can achieve. So this is where I work, Apollo Hospitals, Ahmedabad. This is situated near the airport. And this is another one, Apollo CVHF. It is a dedicated cardiac institute in Ahmedabad near SG Highway, where I work along with Dr. Samir Dani. And this is how our theaters looked, I think, back in 1960s. When cardiac surgery started, theater was full of people full of enthusiasm and full of suspicion again whether cardiac surgery can be done. And this is what we have achieved so far in these, I think, 60, 70 years. Men have been replaced by machines. Now you know that the cardiac surgery is foraying into robotic cardiac surgery, and we are doing a lot of procedures through robotics. So this is, if we talk about metamorphosis, this is how, do we have a pointer or something? Yeah? Kaun sa wala? Yeah? Last, okay. So this is still the gold standard. We call it the median sternotomy. Still 90% of surgeries happen through this. Not all patients can undergo minimally invasive cardiac surgery. However, as the surgeons and the fraternity became more confident about their results, more confident about their diagnosis, this progressed to this. This is called partial sternotomy. This can be either upper or this can be done here, which is called lower. So it can be upper partial sternotomy or can be lower partial sternotomy. So as we moved on from this, we gained more confidence that the same therapy can be done by splitting only the part of the sternum. So we left the sternum alone and moved on to thoracotomies. So mini thoracotomies we call them, anterior, lateral. So it can be right anterior, it can be left anterior, mini thoracotomy. So sternal sparing techniques. And as all of you know, most of you must be conversant with transcatheter therapy. So now most of the therapies are done through transcatheters. This is how cardiac surgery has evolved over a period of these, I think, mostly these 20 years. So if we talk about the evolution as per the papers, you can see in 1994, first mid-cap was video assisted was done. However, since I think till 2006, the results were not good. It was not being, people were not being trained, people were not being exposed. That's why it was sitting in the backyard of our hospital. However, since 2010, the speed of this mid-cap or minimally invasive cardiac procedures has picked up, especially in our continent. Many surgeons are getting trained every year. So how do we define minimally invasive cardiac surgery? It's a small chest incision that does not include full sternotomy. That was defined in 2008. You can see, so back in 94, that's when it started, but the definition came in 2008. That's what I meant, that it was sting in the backyard. So if we talk about the levels of minimally invasive cardiac surgery, so actually we are practicing level 2, 5 to 6 centimeter incision length with or without help of endoscope. And this level 4 is also being practiced right now with the help of robot. We can do a lot of valves, we can do conduit harvesting, and then the level 5 is percutaneous, where we do with the help of transcatheter therapies, TAVI, even the mitral valve can be done, and ASDs and all those VSDs can be done. So why MICS? We were very happy with the standard open sternotomy techniques, and even now 90% of our procedures are done through this open sternotomy. So however, it's safe over a period of time. These last 2 decades, numerous publications, numerous studies have shown, although we don't have proper randomized control trial comparing the 2 therapies, but we do have a lot of prospective and retrospective studies which have shown the safety and efficacy of MICS. So it is safe, and then it is less invasive. Obviously the benefit is translated into the patient recovery, and it is reproducible, as has been shown year and year again, that the younger lot of surgeons are being trained, and I'm sure Parth is also doing minimally invasive, so younger lot of surgeons are being trained in this procedure. So that is cosmetic. The incision cannot be seen at all, especially in females. It's under the breast. So no need to be, kind of, I've got this, I can't wear this. Faster ambulation, on day 1 the patient is ambulatory, and day 2 or day 3 patient goes home. So no sternal complications, since the sternum is not, it is a very scary and frightening photograph. Let's not go there. So this is the road to recovery, faster recovery. So this is the proper incision of the open sternotomy, where we split the sternum through the middle of it, and this is the proper incision. And still I again and again say that 90% of our surgeries are done through this. My at least 50% work constitutes median sternotomy. So this is the mini AVR. You can see the difference yourself. So these are mitral valve surgeries done through that. This is the bypass surgeries done through this minimally invasive techniques. So you can see yourself the difference in the incision, and that difference in itself translates into the benefit to the patient. And nowadays when we talk about cardiac surgery, so there are mainly 2 risks: infection and bleeding. These are the only 2 risks mainly involved. That's what we see in our practice. And both of these risks are remarkably reduced by minimally invasive approach. So this was a study published in, this is our premium journal, JTCVS, published from US. So this was a study published back in 2019, where they studied minimally invasive CABG using bilateral internal thoracic arteries. And this was Piroz Devierwala. He is an Indian surgeon who settled in Canada, trained from Mumbai actually. So he's a big name nowadays in minimally invasive cardiac surgery. So he published his results using, I think 209 distal anastomosis, 90 surgeries, 29 patients were done. And the overall graft patency before discharge was 96.8%. So in open CABG, open sternotomy technique, we have 97.8% or 5% is the patency. So here 96.8%, which is not bad at all. So this was another article published by Sakaguchi. So he also showed that MICS CABG was completed without conversion in 116 patients. So this was back in 2020. So perioperative transfusion rate was 11.2%. Early graft patency was noted in 97%. So freedom from major adverse cardiac and cerebrovascular events was around 89.7% at 5 years. So which is remarkably good. Again, this was a very interesting article, repeat revascularization. This is a very genuine article regarding the repeat interventions after where they compared minimally invasive and traditional sternotomy techniques in 1,468 patients by Peter Olsen from Europe. So they found out that the estimated mean time until a repeat revascularization event was 84.1 months for MICS CABG and 88.5 months for the traditional open sternotomy CABG group. So not much of a statistical or significant difference there. So this is our caseload, what we see in our, what we have done in our practice. So actually at Apollo Hospitals, Ahmedabad, this is the data, I think 1-year-old data at Apollo Hospital, Ahmedabad. So 78% of my patients were triple vessel disease, 12% were single and 11% were double vessel. So 55% of them received 3 grafts, 19% received 4 grafts. You can see even 5 grafts we have done. 4% or 7 patients we did 5 grafts through minimally invasive approach. So that notion that only 1 graft can be done or only 2 grafts can be done through minimally invasive approach, that's not true. It just depends on how you have been trained and how long you have been practicing this technique. So second conduit, so first conduit was always left internal mammary artery. So it is always the question about the second conduit as to what second conduit should be used in minimally invasive cardiac surgery or even in open. That is an open debate that has been happening since I think since cardiac surgery was born. So in my practice, I have used 60% vein, 24% radial and 15% right internal mammary artery. So this right internal mammary artery component has changed now. I think it must have gone up since last 1 year. The data is not there. So 13% received 2 grafts. This is for total arterial bypasses. That is where we use radial and right internal mammary artery for using bypass. So 13% received. You can see 30% and 66% of my patients received either 3 or 4 grafts. So multiple bypasses we have been using. So out of 190, 184 patients were follow-up. 2 grafts out of 557 got blocked. And this is some of the cases, interesting cases which I wanted to show. Actually, very high-risk cases, you can see. So this is another one subset of patients where minimally invasive cardiac surgery can be useful, basically. High-risk patients which are too high-risk to be offered open and too high-risk to be offered angioplasty or because of complex anatomy, because of their morbidities. So 81-year-old female with unstable angina since a week. She was a mother of a doctor, prominent doctor in Ahmedabad. History of PPI in 2013, hysterectomy, cholecystectomy, diabetic since 30 years, hypertensive since 30 years, history of CVA with right hemiparesis, Parkinsonism, OSA on BiPAP, and tobacco chewer and obese. So this was the only good part in her. Echo showed good biventricular function. So we went and this is the angio. I don't think, okay, so I don't have the angio actually, video. So this was the problem. Osteal LAD 90%. Initially we tried her on medical management, sent her home, but she came back within 3-4 days with unstable angina. So I went in to do actually only Lima LAD. So I thought I'll just do the Lima LAD and leave her because she has been having this refractory angina, but ended up doing 4 grafts. And now interestingly, because she was such an adamant lady and very confident lady, you saw that tobacco chewer and all those things. So she used to live alone. She did not live with her children. So she used to live alone. So she is the female. So she used to live alone with a maid. Problem happened, as I mentioned, that we have only 2 problems with CABGs nowadays, that is infection and bleeding. Problem happened after she came to me back that there is some discharge, doctor, from the wound. From the left anterior mini thoracotomy, there was little bit of discharge. I advised her or suggested her to get admitted because she used to live alone, so I thought it is better, you never know. But she refused, very adamant, very confident. She refused and she ended up coming back after 2 days in sepsis and in cardiogenic shock with acute renal failure. So we found that she has ended up in severe sepsis. She was growing Pseudomonas and E. coli from her wound, probably contaminated from her urine. However, she required 2 to 3 days, I think 2 to 3 episodes of dialysis and recovered remarkably well. That is, I mentioned this because at this age, with such comorbidities and with such complication of severe sepsis and acute renal failure, renal shutdown, she recovered within a week's time. It was probably because, I do not attribute it to just minimally invasive cardiac surgery, but it was probably because of the morbidity of the procedure was so less that she didn't develop osteomyelitis, she didn't develop those mediastinitis, nothing, and she recovered. So that is the beauty. So this is the second case where 81-year-old female, again the mother of a prominent couple doctor in the city, history of PCI to LAD in 2004, parathyroidectomy, hiatal hernia, spinal disc dehiscence, lot of things. So echo again showed normal LV. So this is her angio, left main, very bad. So we all again tried to manage her medically because angioplasty would have been, if she would have decompensated in cath lab, would have been disastrous. But she came back again in 5-6 days again I went in with a thought of doing only Lima LAD because of this. So I thought I'll do Lima LAD and leave it alone. But we ended up doing. So you can see here again the right one is also critical. So we ended up doing again 3 grafts in her, and it's been 3 years now, and she's been doing really well. So this is another one very different case. I just wanted to put it in here. So this was a 36-year-old boy. I think this boy required genetic analysis probably. So 10 years ago, when he was only 26-year-old, so that was the first time he suffered inferior wall MI. And since then, he has been having episodes of these inferior wall MI again and again. And I think when he presented to me, the cardiologist had referred him to me. So he was 36-year-old with history of inferior wall MI, episodes of recurrent infarctions over last few years, including CPR recently. So he had arrested recently and revived by the cardiologist and the hospital. So that's when he thought, okay, this conservative management and stents. He was stented twice in his RCA, was not working, so he sent him to me. So before we thought about or embarked on surgery, so we thought we must, because of previous repeated episodes of infarctions, we must get a viability testing done. So we did a viability testing, which showed that inferior wall was viable. So, and then we discussed, because this was my first case, so we discussed with the patient and with the cardiologist, because the cardiologist and the patient wanted arterial graft. They didn't want anything, and he didn't want a sternotomy also. So what we did is we did a minimally invasive cardiac procedure and harvested, you can see here liver. This is the liver, and harvested a gastroepiploic artery from the stomach. And the same gastroepiploic artery we anastomosed here, so this one, gastroepiploic artery to the PDA, going to the PDA. So since this was the first I was doing, so we did an angio as well to find out after a month of his surgery, and he has been doing well since then. He owns a resort in Goa. So this is one of the videos which I wanted to show. I'll just go through fast. So this is how we do this MICS, a small incision below the nipple, left nipple, and this is me harvesting the left internal mammary artery. So you can see left internal mammary artery being divided there. So we get these special instruments for doing these cases. So these instruments cost a fortune. So that's why we don't offer this in Ayushman card, which is being happening. I mean, is the next presentation probably. So this is the left internal mammary artery in my hand. So I'll be trying to check the flow, whether the flow is all right. So you can see there, it's flowing well. So this is me harvesting you can see there the right lung underneath. So harvesting the right internal mammary artery from the same incision. So that is the right internal mammary artery. So it's taking down the left internal mammary artery, a small arteriotomy there, so that I can connect my divided right internal mammary artery onto this artery and make a Y. So I'm sure you must have heard Lima Rima Y. So that's what we do more often. So this was again, this is with his permission, this was again a doctor from our own state, Gujarat, on whom we operated this. So I'll just move forward. Okay. So this is again the LED. So we do off-pump CABGs. So the part where we operate is being stabilized with the help of this blue thing. It's called Octopus. And so if you see, this is on the left-hand side, that was on the anterior or the LED. This is the circumflex part being grafted here. So this is again the same. So this is the posterior or the PLB. It's not the PDA here. It's the PLB which is being grafted. So I'll just quickly move forward. I'm moving forward. So this is the same. Again, this one. This is the left internal mammary artery. This is the right internal mammary artery being anastomosed. And so the left internal mammary artery has been attached there to the LED, right internal to the OM or the circumflex, obtuse marginal there. And this is the posterior descending artery. So the right internal has gone right up to the posterior descending, a branch of the right coronary artery. So we have completely revascularized him using Lima-Rima Y. Thank you very much.
It's a wonderful presentation, sir.
Thank you.
Still in the recent area, so much phobia about cardiac surgery. This minimal access cardiac surgery is definitely an advantage. My quick question is in the recent context of our MACARD and Ayushman, so in your practice, what is the absolute indications for the minimal access cardiac surgery? And what is the learning curve for the younger surgeons?
You mean minimally invasive?
Minimally invasive.
Yeah. So I think one should attempt minimally invasive cardiac surgery only once he is proficient with open. It's like doing open cholecystectomy and then moving on to the laparoscopic cholecystectomy or any open procedure. Once you are confident, once you know the anatomy, once you know what the problems can be. See, only drawback with minimally invasive cardiac surgery is if you have complication, it is difficult to handle that complication. So once you are able to identify those complications before they happen, that is when you should move on to minimally invasive cardiac surgery.
So it's in cardiac it's a different because we see very good zoom effect, but here in minimal access there is a difficulty is more than the.
No, so vision is good in minimally invasive because if you are using a robot and an endoscope, so endoscope is being used in cardiac surgery but not too frequently. But robot, yes. So I've done CABGs using 3D laparoscopic, S-CLAP and all these people have very beautiful 3D, these laparoscopic sets. But vision is very good, but problem is when you have complication. That is the problem. So, and in cardiac surgery, if you have a complication, it's life-threatening. So you cannot afford to have those complications. That's why I said a very important thing, that before they happen, you should be able to identify those, before they happen. So that is when you should move on to minimally invasive cardiac surgery. So that is one thing. But now as surgeons, senior surgeons, including me, there are a lot of senior surgeons in the country who are practicing minimally invasive cardiac surgery since last 10 years, I think 10, 12 years to be more accurate. So as they have become more confident, they have tried to train their juniors. They are trying still to train their juniors so that this skill passes on, does not die with them. So it's important to train them and to tell them that this is going to happen and we should not do this step. That is important. That happens only once you practice. Surgery is such a skill which you practice, you get trained better and better. That's how it is.
Thank you.
Sir, one more question.
Yes.
Sir. Yeah. Sir, what do you prefer, central cannulation or peripheral cannulation in valve cases or on
peripheral? Peripheral, femoral, always femoral.
Okay.
I have never done central for MICS, never done central. Very rare.
Okay. Thank you, sir.
Now I request Chairperson, sir, to please honor the speaker, sir. I request Dr. Harpal Dabi, sir, to honor both the chairperson with the memento. Thank you very much, Sudhir sir, Dr. Vijay Raj sir, and Dr. Parth.
After a wonderful session on minimally invasive cardiac surgery, let's move forward. And we move forward to an entirely different topic where we are talking about Digital India, a mission very close to our Prime Minister's heart. And once we talk about digitalization in India, sitting in Gujarat, we definitely need to remember two Gujju Bhais. Our dear Prime Minister Shri Narendra Modi for his mission of Digital India, and Mr. Ambani for taking digitalization and internet to the remotest part of our country. Talking about digitalization in healthcare, we are here to discuss the Aadhaar card and Ayushman Bharat digital mission. It is a mission with a vision to transform India into a digitally empowered system and where a knowledgeable economy exists. So when we all live in an age where we need Google in our brains and antivirus in our hearts, we'll move on to the next topic. To chair this session, I would like to call upon Dr. K.R. Solanki, sir. He is currently the resident medical officer at Mahua, and he has served as the ex-district TB officer at Bhavnagar. Dr. Solanki, sir. Next, we would like to call upon Dr. Kokila Ben Solanki. She is the district RCH officer at Health Branch, District Panchayat Bhavnagar, and she is working in the public health since 23 years, and currently she is the RCHO Bhavnagar. Over to you, chairpersons, and a warm welcome from our side. We would like the chairpersons to introduce the speaker to our audience.
Now, speaker is Mr. Bhruguraj Praveen Chandra Trivedi. At present, he is working at Joint Director ABDM and State Nodal Officer ABDM at National Health under National Health Mission at Health and Family Welfare Department. His qualifications is BE, IT and MBA. Also got a certified project management profession PMI from USA. He has extensive experience in field of e-governance, dashboard, public administration, project management and data analytics. So now we welcome speaker to go ahead.
With permission of chair, thank you ma'am, thank you sir. Good morning. Thank you to the organizers for setting up the wonderful event and giving us the opportunity to interact with the fellow practitioners. I am Bhruguraj Trivedi, Joint Director IT, Ayushman Bharat Digital Mission and State Nodal for this initiative. I welcome you on behalf of the entire Health Department of Gujarat. I am a bit like Anand of Anand movie. I am person of IT, project management and dashboard. So I understand my subject very well. But as the character Anand narrates the name of the disease, I am also by and large in the similar phase. Bhavnagar is my hometown, so it's always a pleasure to be in the city. Many senior doctors, my elderly is Vadilo. In this attire, they may not be able to recognize me, but it is always a pleasure to be in front of you. Just to give an introduction about the Ayushman Bharat Digital Mission. As our respected Prime Minister, sir, when he was our Chief Minister, he always encouraged us to use the best of the technology, state-of-the-art setup to give the benefits of technology to the fellow citizens, of the last mile citizens, whether in the field of the ration, whether it is field of the revenue, from ration to Prashashan, bringing transparency, bringing the speed to the fellow citizens. And the three mantra that he gave in the administration to all of us is reform, perform and transform. So having these three mantras in mind, the next logical step for utilizing the digital India, bringing the technology in healthcare is Ayushman Bharat Digital Mission, bringing all the stakeholders on a common platform. So when we talk about Digital India, there are multiple initiatives that we have witnessed over a period of time. See, for example, utilization of Aadhaar from UIDAI. You must be aware that we are transferring benefits to citizens directly, DBT. There are no intermediaries, the middlemen, and a rupee sent from the government is the rupee received by the citizen. We all are aware about the crisis or the resistance that, say for example, people had when the computerization was introduced in banking system in early 90s. The majority of you are aware about that. People had the fear in their mind that our jobs would be gone, data would be stilled, money would be transferred, so on and so forth. But now you see the transformation. Now, when we go to a grocery store, when we go for a small purchase, we don't carry the change with us. We are just using our mobile, we are using the UPI, the use of technology. We are just scanning that and transferring the amount. Such a wonderful utilization of technology. And without any worry, it's absolutely safe and secure. So taking this step further, introducing this in the healthcare industry or the healthcare sector, the Ayushman Bharat Digital Mission, ABDM, has been ruled out. So what is Ayushman Bharat? As my earlier speaker had narrated about the Ayushman Bharat, that is only one component of Ayushman Bharat. When we talk about the umbrella of Ayushman Bharat, it covers the preventive cure with Ayushman Bharat Health and Wellness Centers. If the citizen is ill and needs further treatment, then the Ayushman Bharat PMJY, which is fondly known as Ayushman card. And then the third component is to equip these health and wellness centers and the PMJY system is the ABIM with the investment and the equipments. And ABDM is the thread to link all these schemes, digitizing entire gamut of healthcare. That is Ayushman Bharat Digital Mission with the objective of Sarvajan Hatai, Sarvajan Sukhai. So what is the Ayushman Bharat Digital Mission? It talks about an ecosystem where citizen is at the center. It's a universal digital health ecosystem with state-of-the-art digital health system, improving the capturing of quality data with quality dissemination and storage of the data. At the same time, multiple healthcare units, multiple healthcare entities may have different systems. It's very obvious. So to have the systems where they can talk with each other, where they can exchange the data with each other. So interoperability is the key word here. Then when we talk about the health, we talk about the live human beings. So the data that we are having, it must be accurate, it must be updated. So when we are talking about the digital ecosystem, the data or the registries must be updated, it must be accurate for the entire country. And on the administrative part, when we are talking about the data or when we talk about certain objectives, we need to monitor that, whether we are heading in correct directions or not. And many senior doctors, those who are managing their hospitals as well, or they are in managerial roles as well, they will also appreciate that we need data to monitor the quality and efficiency of our setup. So once we are having data, then only we would be able to assess the quality. With the vision and mission, it talks about the inclusiveness. No one is left behind. It should be accessible. We have the extremes in the demography, the illiterate ones to the literate ones, from the poor people to the well-prospered people. At the same time, it should be affordable as well. If it is not affordable, if it is bringing some additional cost, the acceptance level may go down. So it should be affordable. The system must be very efficient. It should be an enabler rather than putting a constraint on the existing system. When we go to the ATMs, when we swipe our cards, it gives the spontaneous withdrawal of money. So on the similar lines, the system should be prompt. It should give the data of patient or exchange of data spontaneously. And much talked concern is of the security of the data. To assure you all, the safety and security aspects, it adheres to the best practices of the globe, best practices of the security protocol is adhered, and it's updated from time to time as per the instruction of the state government and the central government. And the three pillars of this mission is security, confidentiality, and privacy. When we talk about the relationship of the doctor and the patient, the discussion that takes place between these two remains within the wall. So the trust or the bond is very unique. So the basic principles of Ayushman Bharat Digital Mission is the security, confidentiality, and privacy of the data. In no circumstances, this basic principle will be breached. So the security of the data, the privacy and confidentiality data is of high importance. When we talk about the Ayushman Bharat Digital Mission, the basic principle or the policy that has been adopted is highly focused on the security and privacy that is inherent in the design. The user inclusiveness, all users from any spectrum of the demography, they should be able to use the Ayushman Bharat Digital Mission. It is a voluntary program. People can voluntarily join. People can voluntarily opt out as well. And wellness of the citizen is at the heart. The technology enables us to use the single source of truth. As the previous speaker, Dr. Adalati, was saying, if they were having different source of data, then doctor may not be able to treat the patient in better way. So we need to have the single source of truth. We may have different systems which may speak different data, then it would be difficult for us to work upon. Again, it is federated architecture. Any data generated at the given origin, the data remains there only. It is not shared with Government of India or with the state government. The beauty of this entire system is open APIs and interoperability. Multiple stakeholders, be it a small Nukkad family physician or a mid-sized nursing home or a super specialty hospital, a laboratory maybe in Bhavnagar, maybe in Surat, maybe in Ahmedabad, all these may have different IT systems, and it's very obvious. So the ABDM enables them to talk with each other, to exchange the data with each other with the consent of patient. I'm emphasizing on the consent of the patient. Unless and until the patient gives the consent, the data will not be shared, even with the doctor as well. And the frameworks are very standard from the Jammu Kashmir to the Tamil Nadu, from the Gujarat to Arunachal Pradesh. It's a wide nation, so we need standards to roll out the mission with the speedier execution. When we talk about the Ayushman Bharat Digital Mission and ecosystem, there are n number of stakeholders in the system, where the citizens or the patients are at center. The doctors, I mean the super specialty doctors, the general physicians, Ayush practitioners, our qualified nursing staff, up to the last mile medical store person, they are also part of the ecosystem. The regulators like the NHA, SHA, food and drugs regulators, along with them the state government, central government, other policy makers. We are having various NGOs also who are working in the health ecosystem. So they all form the ecosystem. And wouldn't it be useful if they are having single source of truth, if they can use the single pool to access the data? So when we talk about the ecosystem, largely there are two parts: the information provider or information generator and information users or consumers. So all integrated government health management information system or the private health systems, they are the large contributors of the information generators. Then comes the citizens, as they are also having the data, and the health locker, say for example DG locker. At the same time, all such health information system either at government health hospital or at private health hospitals, they may be consuming the data at the same time. The data may be stored by the citizens as well, and of course the data may be stored in DigiLocker or Health Lockers as well. And this exchange takes place through the gateway and consent manager. So unless and until the consent is given, the data would not be shared. So when we talk about Ayushman Bharat Digital Mission, basically there are 5 building blocks. The first step for joining the Ayushman Bharat Digital Mission is ABHA, Ayushman Bharat Health Account, where citizen can have a unique health account associated with him or her, and they can link their health records digitally. It's something like DigiLocker, where we can upload our documents, we can store our documents on DigiLocker, and we can share it whenever it is required. So on similar lines, it is unique health account of health records. Whether I have got a lab report generated in Bhavnagar, and if I'm, say, visiting Kerala or Tamil Nadu, if I'm, say, I go to Chennai, Madras, and I got flu. I had bath in Marina Beach and got flu. Then I can share my previous health records, because in Madras I may have difficulty in identifying the doctors. There may be a difficulty in language as well, language barrier. So when I visit the doctor in Madras, I would be able to share my previous health records. I will be able to share those records with doctor easily without any barriers. So that would be very helpful because of the ABHA. The second part is the healthcare professional registry and health facility registry. This is like the user ID and password. If the healthcare professional is registered in HPR and the health facility is registered under HFR, they would be able to access my personal health record, the legacy data, health records that is stored in the ABHA. The best part, the unique feature is the UHI, Unified Health Interface, as the medical records generated, say for example in Bhavnagar, and if I want to share it in Madras, then the UHI will enable this exchange of data between these entities. And the last part is the mobile application. When we talk about the users, user is able to store the data, is able to manage the consent through the mobile app. It is available both on Android and on Apple. One can download the ABHA application from the Play Store or from the Apple Store. So ABHA is nothing but the 14-digit random number. It contains your name, date of birth, the address, gender, mobile number, email ID, so on and so forth. It can be generated either from the Aadhaar number or from the driving license number. The easiest way is through Aadhaar number. You can just visit the ABDM website, the ABHA page. You can key in your Aadhaar number. You will get the OTP on your registered mobile number. You verify yourself and ABHA is generated. It will take lesser time than the time I took for narrating these 5 statements. It takes 30 seconds or even lesser than that based on your typing skill. So it is as simple as that. It is very easy. Digital health records may be recorded in that, stored in that. Very easy to sign up. It's voluntary. You can opt in at any time. You can opt out at any time. It's very easy to remember. If you forget by any chance, you can recover it through your Aadhaar number. You can recover it from your mobile number as well. And again, I'm reiterating, it is very safe and secure. It is consent-based access. So unless and until I give my consent, it would not be shared with anyone. So when we talk about ABHA, the goal is to cover 100%. There is a difference between the Ayushman card and the ABHA, as my previous speaker was referring to. So there is a small difference. The PMJY card has a rider of income, whether it is 6 lakhs for the general citizen, 4 lakh for general citizens, and 6 lakhs for the senior citizens. Whereas Ayushman Bharat Health Account, ABHA, doesn't have any rider. It is applicable to everyone. There is no barrier of any demography, be it the income, be it the gender, be it the location, so on and so forth. One more thing that I would like to draw your attention, there is no monetary benefits attached with it. It talks about the digitization. The benefits are not tangible here. The benefits are easy to store health records, easy to exchange the data, and it will help the practitioners. Isn't it useful if you as medical professional, if you are having the previous medical history records available with you when the patient is visiting you? Wouldn't it help you for better diagnosis? So these people need a good tea and coffee or a break. Well, I am Anand, but you all are thorough practitioners. So wouldn't that be helpful that when Bhruguraj Trivedi is visiting you, you would be in better position that whether I am having blood pressure, whether I am having sugar, whether I am having thyroid, if I am going through any medication, if I have gone through any surgery in past few months. It would be very useful for you, isn't it? So our objective is to cover 100% population, digitizing all families. We are approaching our existing setup of health department. We are having various days, Mamta Divas, Mamta Clinic, non-communicable diseases day, the Niramaya Divas. But we as a department or a tantra that we say in Gujarati, we would not be able to reach out to entire population of approx 7 crore by this time, 7.5 crore people in that speed. So we may need to have support from various other stakeholders like the NGOs, like other institutes, departments, like the good stakeholders like you, to reach out to the remaining people. Today, as I'm exchanging data with you, it's approximately 3.64 crore ABHA has been generated in the state of Gujarat. And we are in the top 5 states. And last 1 year, we are the topmost states where we have generated the ABHA in the percentage term. The other 4 states which are ahead of us, they have larger population, the UP, MP, Maharashtra and Andhra Pradesh. And we, as the instruction has been given by the top authorities from the Delhi and from the Gandhinagar, that we must be in top 3. The top 1 position is what we are having the reputation. So we should be in that place. But that's a different part. But when we talk about ABHA, it is useful for the health facility and medical practitioners. So there are various enablers from which we can generate ABHA. One is, of course, the Ayushman Bharat Digital Mission ABDM portal. You can scan the QR code and generate ABHA. There are various standees also available. You can scan the QR and you can generate the ABHA. Apart from that, the CoWIN website, we can generate from CoWIN as well. Then there is a PMJY card, we can generate ABHA. We have NCD portal, Nikshay portal, eSanjeevani portal for the teleconsultation, then the TECO application, which is widely used by our government staff. So there are multiple options, even by the Paytm. By Paytm also, we can generate ABHA. There is a small clip, what will help if we are having ABHA, if you can play, sir. If you can play the clip.
Now you can skip the long queues at OPD counters and generate your tokens instantly. Want to know how? Continue watching. This is the OPD counters area at Government Hospital in New Delhi. Every day, thousands of patients stand in these queues to get the tokens for their doctor consultation. This is where the government scheme Ayushman Bharat Digital Mission or ABDM comes into the picture. ABDM brings to you a simple functionality of QR code based faster registrations. A patient can simply scan the QR code placed near the registration desk using their phone. Select the app from the list displayed on screen. Register or log in to share their profile with the hospital to complete the OPD registration digitally. On successful sharing, the patient gets their token number on the app. When the token is called or displayed at the counter, the patient simply visits the registration desk. The patient is asked some basic questions related to their health issues, and the outpatient slip or OP slip is given to them. The patient can now visit the doctor and complete their consultation. By skipping the long queue at the OPD counter, the patient saves time and efforts. Apart from this, under the ABDM scheme, the patients also get the benefit of digital health records. With faster OPD registration and digital health records, the patient gets dual benefits. For next consultation, they can simply walk in, take the OPD token and share previous health records from their app. No need to carry medical files.
Thank you. So the best part is the data entry operator doesn't need to key in the data. And it is not just that we can use in government health facilities, it may be replicated in private hospitals as well. Another part, many of you may be empaneled with the PMJY or may have the insurance facility available at your facilities. Now say for example, you have a patient called Bhrugraj Pravinchandra Trivedi. Now if the data entry operator or the clerk is fresh in the morning time, may not have the difficulty. But as the day progresses, he may type Bhrugraj, he may type Bruguraj, Raghuraj. My FIA didn't ask me, didn't take my consent, what should be your name? And she kept Bruguraj. So now for doctor, it is irrelevant whether it is Bruguraj, Raghuraj, Bhringraj, whatever. You will treat the patient. But when the patient is discharged and when the details are shared with the insurance company, they are having the magnifying lens. The first objective is to reject the claim, isn't it? Now the company will reject the claim. Now the poor Bruguraj, he will not approach insurance company, he will approach you. That boss, I got treatment at your hospital, please see into it. So first few days the talk is very normal, but as the time progresses, the tone gets harsh. And majority of time it is unproductive because of such scenario. So if you are having Abha number, you don't need to key in the data. Bruguraj is expected to key in the name correctly. So it saves a lot of operational issues at our end. Next, please. I can change. When we talk about HPR and HFR, the best part is it enables us with a recognized or a verified database. In today's world, we find a lot of tents with Siddha Yogi, Himalayan Siddha Yogi, 100% Nidan, Sachot Nidan. So we can get rid of all this because of or with the help of verified database. When we talk about the HPR, when we talk about the HFR is verified by the respective medical councils. They are also having the magnifying lens. If there is a small difference in the spelling or date is different, then they will reject. So is the case for the health facility registry, where our local district health officer, chief district health officer, and the corporation MOH, they are the verifiers, and with given care, they are assessing the applications and approve the applications. I'll just give you an example. We are having more than 17,000 applications in HPR, but today only 4,000 applications are approved. So it's not that one has applied for HPR or HFR, the application is approved. So utmost care is taken at healthcare professional registry, at health facility registry, so that to have a verified database to the citizens. As a citizen, if I want to know that what sort of facilities, say for example, I want to visit Optho in Gandhinagar, I'm aware about the Bhavnagar, that who are the good doctors for Optho, but I am very new to Gandhinagar. So if I want to search who are the good doctors, what are the facilities available in these hospitals, then HFR is a good platform where we can get all the details about the respective facilities or about that doctor as well. And again, you can always check or uncheck the details that you don't want to display it in the public forum. It's very easy. It's just a pictorial form. It will go to, if it is government practitioner, it will go to the work verifier of government. If it is a private practitioner, it will go to the respective medical councils. It will get verified and it will go to the database. So a personal detail is fetched from Aadhaar. You just need to upload your registration and academic details, the work details, and you need to just submit it. It takes 5 minutes if you are having all these details handy. It's very easy. It's not that time I'm saying, and you should believe this. You should also try and check it once you go back. And this is the health facility registry. Facility manager submits the data, goes to the district verifier. District verifier checks on the given parameter. If he is satisfied, then it goes to the district nodal officer. In this case, CDHO is the district nodal officer. These go to the public or the database, online database. Another important aspect, it was discussed in recent G20 held at Gandhinagar. We were having the presidency of G20. So the best part, the ABDM was demonstrated before the delegates of G20, and the best part is Heal by India. So the HFR and HPR, it will not just enable our local citizens, it will also help us in boost the medical tourism. It will help us in bridging the citizens abroad to come down to India and take treatment. One more thing is the incentive scheme, digital health incentive scheme. The government of India gives 20 rupees per patient per transaction. What it means is Bhruguraj Trivedi having Aadhaar number gets the prescription generated. The entire cycle gives 20 rupees. Bhruguraj Trivedi Aadhaar number generated, lab report submitted, another 20 rupees. Aadhaar number generated having CT scan or X-ray images, 20 rupees generated. So one patient having Aadhaar number and multiple transactions will give 20 rupees on each transaction, and the cap is 4 crore. So Government of India, National Health Authority will directly deposit this amount in the health facilities account. There is no role of Government of India, ministry or state government or state ABDM team in this transaction. NHA and health facility direct transactions. So this is all from my side. The basic, our core objective is of Sarve Santu Niramaya, the Ayushman Bhava campaign, which is inaugurated by Honorable President of India on 13th September, keeping no one left behind. So we are on aggressively we are covering our remaining population to achieve the 100% saturation of Ayushman card. And I would love to iterate one more initiative. We have already saturated the government health facilities. Now we are targeting to reach out to you all private healthcare practitioners, because it is a major contributor in our entire ecosystem and a key stakeholder. So unless and until we have active participation from you, we would not be able to justify the mission. So we would love to have your participation in ABDM. We would love to have your feedback, and the buzzer is also up. We are going with microsites. The district team is here, the corporation people are also here, and HLF PPT who are going to work with us on microsites, they are also here. So thank you all, thank you very much for being a wonderful audience. It's always pleasure to be in Bhavnagar, and I keep looking forward for having such opportunities, and this is one of the reasons for having microsites in Bhavnagar as well. It's a secret. Thank you all. Any questions? We are running out of time, but still.
Yes, sir. Quick question. First is, for practitioners, it is voluntary or mandatory?
As of now, it is voluntary, sir.
Okay. Second, will it be recognized as a national ID like Aadhaar and PAN?
Yes, it is. I'll just narrate one example, if you permit. I was as part of the study team who visited Andhra Pradesh for teleconsultation program, and out of the enthusiasm, I volunteered as a patient in one of the remotest village of Andhra Pradesh. I shared my Aadhaar number, and to my surprise, the details that I have uploaded was visible there. So that's why the confidence is there in the tone. So it is across all the states, it is available, visible.
Okay. Sir, as you are representing the Gujarat state, this is not a question, suggestion to you and the dignitaries on the dais.
Sir, please.
Whenever we roll out any plan, we have lots of plan in the health sectors. we find out the venue, then HR, and then infrastructures, and then gadgets, and then SOPs. This is very difficult. We don't have dedicated HR and gadgets, as it is a technological intervention.
Absolutely.
And one person is engaging with, at a time, 5 programs.
Absolutely.
And we find difficulty in internets and computer and laptop. So it is a request on behalf of our IMA, Gujarat State, Bhavnagar, as well as Government Medical College Hospital.
True, sir.
At state level, at least you plan in a such a way that the rollout will be smoothened. It is a real hurdles what we are facing in other scheme. So it is my humble suggestion.
Well taken, sir.
Thank you.
Anybody from the audience, any question? I happened to be a faculty during my earlier days, so I had that grip that I can convince entire students 100%. So you are not having any questions, so I doubt myself because I got married after that. So 100% સમજાવી શકાય હવે એવી ગ્રીપ પડી ગઈ છે. But still there is no question. Thank you so much for a wonderful audience. Thank you to the chair. Ma'am, please.
Thank you. Very informative and useful in current digital health records time. All person have ABHA card. ABHA account must be created. સરે વાત કરી મેહુલ સરે એ રીતે કે દરેક પ્રોફેશનનું રજિસ્ટ્રેશન બી થવું જોઈએ અને દરેક ફેસિલિટીનું રજિસ્ટ્રેશન થઈ જાય અને આભા અનેબલ સોફ્ટવેરનો ઉપયોગ સ્ટાર્ટ થાય. ઓકે, થેન્ક યુ.
Thank you, District Health Society team and the organizers for giving such wonderful opportunity. Thank you all once again. Thank you.
We would request the chairpersons to honor the speaker. Madam and sir, can you do the honors, please? I think this is set to digitalize healthcare system in India, and it's a revolutionary step. But as Dr. Mehul rightly pointed out, that we need more staffing and more people who are, very accustomed to computing rather than in a medical fraternity. So some days we feel we are more of clerks than doctors. So I think we need more support from the government because everything has to be put online. So it becomes very difficult. We have to focus more on that rather than our patients. I would request Dr. Shivanand Jha sir to felicitate these chairpersons. Dr. Jha sir, please, can you do the honors? Thank you. As we celebrate World Internet Day, this is again one of the most revolutionary presentations of this conference, I guess.
હવે જે નેક્સ્ટ સેશન છે એ ફ્રેશર્સ માટે કદાચ વધારે યોગ્ય છે. કન્સિસ્ટન્ટલી સિન્સ લાસ્ટ 3 terms, and he has been awarded a National Level Dynamic President Award in 2023. He is very active in all other IMA activities like biomedical waste plant, IMA matrimonial sites, IMA MSN, IMA JDN, and IMA Credit Society, etc. And sir is the Chief Medical Director of Dr. Kiran C. Patel Medical College and Research Institute. Welcome, sir. Please take over.
Good morning, friends. ત્રિવેદી સાહેબનું લેક્ચર આભા ને આપણે બહુ ડિટેલમાં સાંભળ્યું. જે લોકો PMJનું હોસ્પિટલમાં લીધું છે પરમિશન, બહુ જ ઇન્ફોર્મેટિવ હતી. હવે પછીનું જે ટોપિક, ઇટ ઇઝ વેરી ઇન્ટરેસ્ટિંગ ટોપિક. ફ્રેશ પ્રેક્ટિશનર માટે હાઉ ટુ પ્રેક્ટિસ. I request Dr. Mitesh to introduce.
Welcome you all. Dr. Seema Bose. She is in SCG Care Center head. Dr. Seema Bose is a senior healthcare professional having experience of more than 15 years of experience in industry with diverse and extensive background in healthcare leadership, hospital commissioning, and medical healthcare operation, management, clinical practice, direct patient care, and medical. Yes, welcome. Skill in developing in implementing quality improvement initiative to optimize the patient care outcomes. She is an external NAB assessor as well, currently working as the clinical head of SCG centers, Ahmedabad.
Yes, next our person is Dr. Parth Desai. I request Dr. Parth to come on the stage. He is a Chief Operating Officer in Kadi Hospital, Ahmedabad. He is passed his MBBS in Kesar Medical College, MD Pharmacology, SBKC Medical Institute and the Research Center, post-graduation in Health Management, Indian Institute of Management, Calcutta, post-graduation diploma in Medical Laws and Ethics, National Law School of India, Bangalore. He is a gold medalist in MD Pharmacology, received many awards and accolades for the hospital management. Current positions is Legal Director in Professional Protection Scheme, PPS. Additional editorial board member, Gujarat Medical Journal.
Our another panelist is Dr. Pranav Sharma, MBBS, Pramukh Swami Medical College, Karamsad, 4 university gold medals, MS General Surgery, BJMC, Ahmedabad, MCH, CVTS, AIMS, New Delhi, PGDHHM, Healthcare Management, Medical Legal Science, Symbiosis, Pune, former Chief Medical Administrator and Professor of Cardiac Surgery at UN Mehta Institute of Cardiology and Research Center, Ahmedabad, founder the Dr. Pioneer Academy, founder Krishnamacharya Healthcare Private Limited.
Yes, I request Dr. Darshan Rai Shukla. Welcome, sir. Sir passed MBBS and MD from CMP Shah Medical College, Jamnagar. Is a pre-lancer anesthetist and painkiller management last 2002-2006. He is a critical care consultant from 2008 to 2013. He created first private limited company of critical care in Gujarat as a group practice, completed MBA in hospital management last 2011. Since 2014, hospital director at Sri Bhajandas Bapa Hospital, President IMA Bhavnagar for 2019-2021, and I must say he did very good job for the COVID vaccines era, and he received also recognized award from state government. Thank you. Yes, I request Dr. Chandan. He is very enthusiastic pediatrician of Bhavnagar, very dynamic person, very active in IP Bhavnagar. He is a specialty in SCITS allergy, asthma immunotherapy clinic, Nandavan Sishu Hospital, consultant pediatrician and pediatric allergist, immunologist. Pediatric allergy, asthma diagnosis and management include food allergies, allergic immunotherapy. He delivered many allergy talks, including allergic skin test, PFT, workshop, among the pediatrician, ENT, pulmonologist, and GPs. He is the founder and director of Allergy Free telemedicine platform for allergy patients. He is also a good writer. He is author of the e-book 50 Ways to Prevent the Repeated Cough and Cold Due Allergies. This topic is very interesting topic because this is day to day and the fresher doctors coming to the society, how to practice. It is very interesting. આમાંથી ઘણા જ નવા એજા ફ્રેશર જે ઇન્ટર્નશીપ આવ્યા હશે એને બી ફ્યુચરમાં હાઉ ટુ પ્રેક્ટિસ ધીસ ઇઝ વેરી ઇમ્પોર્ટન્ટ. I request Dr. Chandan to handle the session.
Thank you, sir, for such a nice introduction. So, good morning, respected seniors, my dear colleagues, friends. Today, everybody's dream, every passed out fresher's dream, either is MBBS, PG or super specialty, is to to have a very good private practice by name, fame, and of course wealth. So, taking this topic, because it is being a doctor and being an entrepreneur, both of things are having a gray area there. So, this thing, being an entrepreneur, is never taught in medical schools or very less discussed in scientific forums. So, this gray area I addressed in today's session. How to go systematically in starting a private medical practice for a freshly passed out doctor. Nowadays means there are around 1 lakh MBBS passing out every year. Around 45,000 odd postgraduate students are passing every year. Private hospitals are increasing day by day at a compound annual growth rate of 18% compared to population growth of 1.2% merely. So around 15% more rise in hospital rate compared to the population growth. So for any freshly passed out graduate or postgraduate, what is the first thing that comes in your mind? साला सरकार ने तो देश की वाट लगा दी है इतने डॉक्टर्स बना के. Then we ask, what are your future plans to a freshly passed out doctor? What are you doing in future? अपन को कुछ समझ में नहीं आ रहा, मगज में केमिकल लोचा चल रहा है पूरा. This approach, when we say to our parents that क्या करूं मुझे पता नहीं है, they question our own existence. They ask, because for a layman or non-medical parents, being a doctor is the safest thing in the world. So when we have some doubts, these are things that are coming. These doctors now go on for looking for some angels from God to solve their problems. They are go on asking other experienced doctors for it. And then comes Bapu, who came here for Munna Bhai. जब भी मेरी ज़रूरत हो आ जाना, मुझे याद करना, मैं कहूँगा. Such Bapus, 4 of them are there in our stage, and I am sure that there are many Bapus in the private practice that are ready to help the freshly passed doctors for it. So as Bapu is there, we'll ask each and every Bapu or we'll ask each and every doctor the questions that are commonly encountered in our problems in day-to-day practice, how to start a private practice. First of all, my first question is for Pranav Sharma, sir. What are the key legal and regulatory requirements for setting up OPD medical practice?
Thank you, Chandan, for keeping this topic and inviting all of us, because there is a gap. There is definitely a gap between the people who are already established. Sometimes they are also willing to help, but we'll ask them what they'll say. Chokra ko yahan aata na the humne pucha. Ye to mannuj kar rahe. And then students or the freshly passed out students will be going to them when they are at the peak of their work or they are busy in their work schedule. They say they don't guide us because we are their competitors. So even if they want to help, there is no help available. With that intention also, I started this academy in which we are helping the young doctors to become independent entrepreneurs. You can see in the audience, there is very thin attendance of young students. Most of them will be having a tea or coffee. So basically, there are not many legal and regulatory conditions. I'll just explain in 2 slides. So, see, first 3 things are important. If you want to have an OPD setup, and these things are actually important because sometimes what happens, so many doctors are running their own show and they are not having some permissions. So if you will go to them and for guidance, they'll say कि मैं तो नहीं दूँ, ज़रूरत नहीं पड़ती. But जिस दिन ज़रूरत पड़ती है, then your hospital will be the first target. So it is better to have these things. First is you all have a registration under Indian Medical Council. That is there with everybody. Only the quacks will not have that. Second thing is CE. CE Act is under a lot of doubt and a lot of discussions in the last 2 years. And it is in action, but it is not implemented as yet. So
to get a CE certificate, you need a PCB, pollution control permission for waste disposal and all. You need a building use or a rent agreement, and you need a fire clearance. Fire clearance or fire NOC. So if you have these three things and Shop and Establishment Act from the local municipal authority, these three things are more than enough. Now these are in the various stages of implementation. So if you will go to, for the CE Act, they'll say that 50 bed thi osha mein zarur nahi hai and all those things. So you have to check the local authorities and the local rules for that. But more or less, these three things are the most important. Then there is a concept of brownfield and greenfield. So what is that? Brownfield means existing facility of health is there, some old hospital or some other building was used for some other purpose, and it has been now you want to use it for your own practice. That is the existing setup which is partially built, or you are renovating it or making some structure out of it. And greenfield means you have a land and you are making a new hospital on that. So to consider the two differently. And if you are having a rented facility, you have to have the rent agreement, and you should go in detail in the rent agreement, because so many times initially dosti yaari rishtedari mein kya hota hai, they give it, we take it, we don't read the documents, and then later on we suffer. So when the fight comes, then you start reading those letters. So I advise that you should do some detailing of the registered rent agreement, especially if you are taking things from the friends or family. That is a big inhibition initially, but you should be having clarity in that. And then is a very important thing that always get a fire NOC done by the owner. You should ensure that he has done the building has a fire NOC certificate or NOC from the fire authority. And that should be done by the owner, because if you have taken it on rent, if you will go, then your documents are not enough. It requires the final documents from the authority, from the owner itself. Then important thing is what you should think about when you are taking a pre-built structure. You are starting an establishment in some building, what all things it should be having. So first thing is water supply. 24-hour water supply should be there. Drainage, clean and clear, because once it is done, it cannot be undone, and that involves a lot of financials to redo it. Third is the floor, which will decide the fire NOC. Electricity is there, and finally power backup is there. We don't have that much problem in Gujarat, but then still these should be having in your whole these things you should be taken care before deciding a pre-built structure. These are the basics about OPD practice, or mainly OPD and daycare structure. These are the requirements.
Thank you, sir, for these valid points. Now, for indoor hospital, license is a certificate. What are your views about, Saib?
So indoor practice is a little extra other than this. See, you have already the building plan is there. You have to take a pollution control board. You have to take AERB is very important permission. There are so many doctors who are in our academy, and there are students from all over the country. They start digging the earth before getting an AERB permission for the bunker. There are students like that. So this is very important, because AERB is a body which actually passes the plan, passes the structural designs, as well as after post construction also it comes for the permission for starting the radiology facility. So AERB should be considered at all the three stages. If you are having a radiology or radiotherapy setup, you have to consult AERB in all three stages. Then comes the pharmacy license. So everybody will agree that pharmacy is a good source of income, and you must have it in your setup and properly done. So for that you need a license for pharmacist. Lift you are having, you should have a lift license. And DPR and feasibility report. This is commonly used terms, but what is it having? So DPR is actually your plan on paper, right? If you are planning a hospital, what all doctors you will have, what all facilities you will have, how will be the flow of the patient, how much area you will allocate, what will be the structure, which floor, which facility will be there, how the flow of the instruments will happen. So all those detailing, more detailing you do in DPR, it is easier for the architect to plan as well as you to implement. Both the things it is there. And feasibility report. Feasibility report is actually financials of the project. Like how much is the revenue, what is the estimated price you will keep, how much will be the ROI, when will the ROI happen. Usually happens in 5 to 7 years. But you should have an idea that, because this feasibility report is also required for the banks to give loans. If you have a good feasibility draft, then people in the banks will be assured that our money is invested in the proper way. That is very important. Then comes the, if you are, these are before construction. Then during construction, you will require a NOC from a fire department. Once the building is ready, you will need a BO permission. Excise permit if you are requiring spirit. Then again, registration under CE Act. So this is, if you have more than 50 beds, then you have to need that. If you are wanting to open a blood bank, then you will require a Drug and Cosmetic Act permission and consent to operate from Pollution Control Board. Now sometimes what happens, we should consult these people for Pollution Control Board and as well as the fire department while you are making the building also. It is one extra visit, but that will save you a lot of things in the end. But if they start some requirement in the later part of the project, then it is a redo of the work. So get in touch with these people in time. And then there are some of the not mandatory permissions. Like if you have an ambulance, then you will require the permission for that. FSI license for kitchen, license of firearms. Diesel generator is important because of 24-hour electricity. Medical gas licenses, narcotic drugs if you are having anesthesia drugs, and PCP and DT if you are having a ultrasound or echo. Finally, 2 more permissions. ESI will come in action if you have more than 10 employees, and EPEF will come in action if you have more than 20 employees. So we will recommend that don't take, if it is manageable, then don't take these many people on your board, on your roll. There are agencies which supply the people, and you can take the directly for services, and they are more accountable also.
Thank you,
You can
sir.
take a snapshot of this. You can take a picture of this, and this will help you when you are planning your setup.
Thank you, sir. Sir has very nicely put all the 2 years' work in 2 slides altogether. So each and every work is a headache, and sir has very nicely placed the mind map in this form. So my next question, the first things come first. For a fresher to start a practice, right location is the most important thing. So I would like to ask Soma Boss Madam, what are the important factors the doctor should consider while selecting the location for the practice, madam?
The first thing in which a fresher should see is the convenience of the location. Now, given the heavy traffic, the the spacing out of regions, every customer or the client or the patient, whomever, whatever we say, they would like to find a doctor jo ghar ke paas ho. The convenience should be location. So as a thumb rule, maybe 10 to 15 kilometers is what we should think. And it also depends upon our practice. So suppose if I am an ortho and I am more into TKRs, so a location in which there are senior people, more disabled people, maybe I would like to be closer to them. Similarly, if it's, we have a sport complex nearby and I'm into sports medicine, maybe we would like to do that. So the convenience is the location, the first thing which we would look. Again, then there is as we all know, parking and traffic. Whether it is Ahmedabad, whether it is Bhavnagar, everywhere. So your location should have some available parking. If it's free parking, more better. And then there should be a little space in front where there can be easy drop-off of the patients, especially if, again, it's ortho or trauma kind of patients. Then how is the neighborhood? We should, this, I think mostly it is estimated, but neighborhood is very important. It has to be an open and a friendly neighborhood. It should be safe, correct? And then we should also see the future developments. Now suppose we select a place. Aaj to bahut acha dikh raha hai. There is a good visibility, your clinic is good, but then we should look into the town planning. Maybe after 3 years or 4 years, you have buildings and huge constructions coming up. There is chaos, there is traffic, and somewhere your clinic is lost. So that doesn't work. So maybe we should look into the town planning or something. Then again, if it's a single proprietor or partnership. So if you are single, then it's fine. You can choose anywhere. But if you have a partner, your partner should also find that place convenient. He must be willing to come every day to that place, for a long association. So that is also important. And of course, staffs, you need good nurses. You need reception people. You need some paramedical people. So after getting good quality nurses and all, you will have to train them. So maybe for a year you are going to train them. Then you should be able to retain them. Suppose it's too far away and they are not coming. You are in the suburbs and they don't come after sometimes you have attrition. That doesn't really work. Okay, and of course amenities. So all amenities nearby, lifts, spacious lifts if it is in the, if you are into ortho and all, ground floor will work. You know, all these things would be very important. Okay.
Okay, thank you, madam. So there is gradual decentralization. First people were coming in the center, now they are gradually moving in the residential areas.
Yeah.
Any factors, consideration that is important for success of various specialty wise, any factors affecting it?
Yes. So we should go into the demographics also. So age, sex, education, and especially socio-economic factors. Place having low socio-economic factors may be cheaper for you, but then it doesn't work. They might go into government schemes.
Paying capacity is
Paying
less.
capacity is not there. So all these things have to be taken into considerations. Again, a mature community, suppose it is already set, you may not want to open a new place. They have their set doctors. They may not come to you. If it's a newer upcoming community coming up, you can open there. Again, of course, if you are a pediatrician, a school, colleges, young populations will help you. So those things we will have to, keep an eye on. And of course, with the, kind of cost and all, everything coming up. So accessibility, visibility, marketing, they will be taking it up. All those things, for that, you will have to keep the location in mind. Of course, if you are having a standalone nursing home kind of thing, so pathology, radiology labs, pharmacy, if you don't plan to have in-house, you will have to look into that.
Thank you, madam, for such nice
It's in the
inputs.
gist, yeah.
So these are the summary for demographics that will be very important for the child. Now coming to the most important part is finances, financial planning for success. My question is for Parth Desai, sir. How can a newly graduated doctor or postgraduate doctor can secure funding in their private practice? Is there any way that they can secure their funds initial startup?
Thank you for the question. So there are different modes whereby we can set up our own clinic. So first, definitely the easiest method to get the funds are the bank loans. As Dr. Pranavbhai also said, that we need to have a detailed project report along with a bank loan report, which can be submitted to the banks, and depending on the project envisaged by the bank, generally we can get the funding. Cooperative banks, private banks, nationalized banks, all of these do offers good bank loan to the doctors, considering we being persons will be honest in paying our debts. So yes, that's first priority. Second goes as investors. So in investors, to the freshly graduated people, I would like to say that if there are known investors, it's better for you, so that it is better managed in your own day-to-day practice, because the pressure of other private equity investors and venture capitalists to manage those things for the newly graduated can be a tough thing. So if there are known investors in the projects, it's definitely better. Bootstrap is having your own funds and managing your own hospitals. Again, the easiest one if you have funds. But then as this healthcare cost is rising rapidly with all the biomed equipments and infrastructure cost also, it tends to be difficult that you bootstrap your own clinic. And even if you try that, you will be ending up making a very small or with lesser biomedical equipment the setup. So chances of running the clinic might be compromised. So defining scope of services and then getting funds for it is very important. And lastly, grant. So government of Gujarat also has many schemes of setting up healthcare institute, including financing of biomedical equipments in some of the regions where healthcare is deprived. That's also a thing to look for, and how do we harness the potential of MSME for the hospital as well is very important. Thank you.
Thank you, sir, for nice inputs. Now MSMEs are, government is giving grants. That is one of the good thing, because the cost of building hospitals is increasing day by day, and all investors ask for share, and that is very difficult for a doctor who is working hard day and night to give share to the investors. Now my question is for Darshan Shukla, sir. What are the typical costs associated with setting up and running a medical practice, as you are associated with Bajrang Das Bapa Arogya Dham? So we would like to know this, running medical practice, what are the costs associated?
From we
wake up to sleep, there is cost involved. So your question is for running a hospital. Main thing is if we divide cost in three parts. First is for doctors, then for infrastructure, and third is for your business. The first cost is, this slide I think is for starting up, so we can remove this. This is already covered. So the first cost is of starting a hospital is that if we see for a consultant, licensing yourself, your registration, your personal insurance, and if I suggest everyone that while you starting your career, you should have a term plan. If you are borrowing money from anywhere, if you are taking loan or borrowing, you should insure yourself first. Then if we see for the infrastructure, there is a huge cost. Everybody has said, so I will not go in deeper. For cost of operational cost, if we say, then that is the HR cost is main. Consultant cost, yourself. You take some fund from your own house running. So that you also include in your cost. This is basic cost is of that. For running hospital, from water, electricity, sanitation, and government expenses, there are fixed expenses and recurring one. All one should count. But this is depend on your private practice, what you want to start. If you want to start a clinic only, then cost will be different. And if you are going to start a big hospital, cost will be different.
So basically, sir is telling that it is the cost depends on which infrastructure you prepare and what are you doing. But there is cost associated with every good thing you do in this world. And so we have to arrange our finances accordingly.
One thing I want to add, that now NABH is available for OPD also, single clinic, they are giving NABH, one should prepare for it. And see, the cost is huge nowadays. If anyone is starting career, પહેલા શું હતું કે આપણને બેંક ડૉક્ટરની ડિગ્રી જોવે ને they can give us loan easily. Certificate છે, yes, so you are eligible for loan. But in this current era, one should consider about one person company. I think all are aware or not, there are private limited companies, LLPs are there, but single person company you can make.
Okay.
Previously it was proprietorship, but now one person can make company also.
Okay.
And bank will trust a person is less than a company. If you are having your company and you are starting up the hospital or clinic or 10-bed clinic, your company valuation will speak more than your personal level.
Okay.
So that also can be considered.
This is good way to increase our capital, and we can borrow more from making this. So now moving to next question for Soma Moss madam. Should doctors specialize in emerging areas of medicine, or should they stick to the older classical specializations?
I think Dr. Chandan gives all the tricky questions to me.
Yeah. Yeah.
Okay. I think every branch has its own niche area. Every branch is important. But then among the conventional branches also, there are upcoming technologies which I think by 5th year, they all are ready. They know which branch they will not take and which of the 3-4 branches in which if they go, they decide. But then few branches which I would like to highlight on is they can think of dermatology. Dermatology maybe a decade before it was diseases of the skin. Nowadays it is no longer that. That is passé. Okay, nowadays it is all about laser treatments, skin acne, scar removals, Botox, fillers, and then you have skin regeneration, they are doing a lot of things in that. So you also have apps coming up, there's an app called Skin Vision. You take the photograph of your skin, the app, the melanomas or a mole which you have, you can send it to your doctors. So dermat is coming up in a big way. So also is radiology. I think somebody might contract ki radiology has AI also coming in. But then we have, radiology as well as nuclear medicines. A lot of technologies are coming up. You now have mobile MRIs also coming up. Digitalized PET scans coming up. There are better radioisotope molecules which are coming up. FAP is coming up. So, given the importance of evidence-based medicine, radiology is doing very well. So, they can also think of radiology. Ophthal also, with previously it was only cataract and maybe glaucoma treatment. Nowadays, you have 3D convex lenses coming up. There are bionic eye implants coming up. So, ophthal is also coming up for macular degenerations and all. And oncology, as they all know, the younger ones, the younger students. Oncology, you have immunotherapy, precision therapy coming up, targeted chemotherapy, genomic sequencing also coming up. So oncology is also a field which is coming up. The newer upcoming branches are medical genetics. So medical genetics is coming up. You have geriatrics coming up. Given the age shift is now towards life expectancy has increased up to almost 70 years as per ICMR. So they can think of geriatrics, they can think of preventive medicines. Preventive medicine is taking care of the chronic debilitating diseases which they might face and having active life interventions into it. You have palliative medicine coming up for terminal cases. Then you also have gene therapy coming up. Genetics and all, regenerative coming up.
In short, in newer branches with good technology in future are the emerging branches that are helpful for
with
them.
AI and everything, they are all coming up. They can think, the students
Now
can
we'll
think
quickly
for that.
move to the next question for Darshan Shukla, sir. What are the essential equipments that are required for modern medical practice? Any infrastructure requirements that
infrastructure is I already told, it should be fit to size. As a person want to start a single clinic, then 10 beds or 5 beds, and if a big hospital, then accordingly. But if they want to consider cashless government yojanas, it is must, then at least they should go 20 bed or plus.
Okay.
That is must. Rest.
Okay. And sir, for any latest technological trends what the doctor should be aware of, for a question for Pranav Sharma, sir.
Actually, these latest technologies are relevant to not only the new upcoming doctors, it is also relevant to the existing doctors. Because if we will fall behind in these technological advances, then even if you have a dinosaur, you will be outdated, right? You can get extinct. So there are things like telemedicine which is coming up in a big way. You should take advantage of that. Even in Corona, we are using it very extensively, but we are not using it that much. But I will recommend that for follow-up, you can always use telemedicine, because every time the patient doesn't have to come to you for the treatment and just mild or minor modification of the doses. So you can do that. And EHR, as ABA and all these are coming up, now EHR has made the whole thing more easy and it is more acceptable to the people now. Then comes the artificial intelligence and machine learning. This is a big thing. and everybody has to imbibe that. And Chandan is already using it, and he's found it very useful, and everybody has found it useful. The chat GPT has come like a storm. And then wearable health technology and health exchange platforms, Internet of Things. So basically wearable technologies are coming up in a big way. The phones, the smartwatches, the smart specs, these all are...
Everything related to technology is mentioned in this slide. Now these newer technologies we have to adopt in our day-to-day practice, otherwise there will be difficult. So we doctors are very weak in these things. So ऐसे कामों में हम कमज़ोर है, इसलिए we'll take of the help of the doctorpreneur community to in case of ethical and successful marketing. What are the marketing strategies, sir, Pranav sir, that we can adopt?
There is only one marketing strategy. You have to build your brand. Whenever patient thinks about their problem, for example, they think about a skin problem, you should be the first person coming to his mind or her mind. That is a prime mantra for the marketing. And how can you do that? You can be an influencer in any way. You can create YouTube videos, you can create materials for their education, don't tell them come to me. If you will do that, you will be caught by an MC and they'll say that you are promoting yourself, propagating yourself. No. Give value to them. Give 10 times more value to them because you are giving on the online platforms. So if you make a video on cough and cold, it will be seen by millions and millions of people. And especially make it in vernacular language. You make content in Gujarati. Because even if a IIM or a Harvard graduate, if he is a Gujarati, he is happy to listen in Gujarati language. So don't be shy of any vernacular thing. Create in your own language and create a lot of material. This is about digital marketing.
Creating local content, relevant content is the need of the time, according to sir, and it will not come into NMC guidelines. Nothing is, because we are helping the people by creating content.
See, if you are there doing it genuinely, people will find out your phone number and find out your address, everything. But that thing should be kept in mind. You should be the first person whenever he thinks about disease.
Thank you, sir. Now quickly moving to next. My question is to Parth Desai, sir. How can we effectively generate good revenues initially in our initial initial days of practice?
So as Dr. Pranav said, it's nothing but brand building. So we need to build our brands. For that, we all have limited spending. So how do we spend our presence on social media? How do we target the specific population for our own hospitals is very important when we are doing digital marketing, including search engine optimization or doing boost ads on Facebook, Instagram or anything. How do we hyper personalize the content for the target audience is very, very important. And seeing into it that our brand is building by word of mouth from patient to patient. So one happy patient definitely can influence others, and one negative can negatively influence 10 other patients. So negative experiences in our hospital should not be there. So as an admin control, it's very important to see that anyone coming into our door, be it an OPD or IPD patient, is getting satisfied and they are spreading word in the community. That will bring more patients for all the newly set clinics and everyone. And lastly, I would just say that we all forget the social impact of the hospitals that we all are therein. We all definitely are there for the business of healthcare, but along with that, if we are actually able to do a social impact in the nearby community, trust me, it makes a business sense as well.
Thank you, sir. Because of the lack of time, just one question, sir. Sir, my question is to Pranav Sharma, sir. How to go about solo, group or corporate practice for a newcomer?
There are pros and cons of each of them. But you should be knowing yourself first. You are a team person or you are a singular person. You love cricket, you love football, or you love badminton. So if you are a team person, go for team. If you are a solo person, remain solo. There is nothing right or wrong in any of them. At the same time, you should know your branch also. If your branch is dependent on other branches, then you can tie up. If your branch can remain independently and it can survive, then you have to go for that. And I will request all the newcomers and boys and girls who have just passed out and they want any help. We have a consulting, so we have given the brochures to Chandan Bhai. Whoever is interested, they can take it.
Thank you, sir. Thank you. It is much relevant in this time. And how to give a good quality, high standard care with ethically because ethical practice is very, very important nowadays due to some strict guidelines. So good ethical practice to Parth Desai, sir.
So due to paucity of time, as this is a very lengthy topic, but what I would say is to have ethics in our own practice, definitely it's very important. It won't be rewarding in the short term, it's a long-term game. We all understand what are the tricks and tips of doing a business as of now, how the practices are rampant in our medical profession. But this is a long-term game. It pays in long term when patients and your own peers are recognizing the quality work that we are doing, and over a period of that, then we are not able to dependent on others for the practice that we are developing.
Thank you, sir. Because of the time constraint, we will not take further questions, but any doubts you can ask personally to all our four expertise. Thank you. Thank you for giving the time. I will end my talk with this शायरी. मंजिल उनकी नहीं मिलती जिन्हों सपनों में उनको मिलती है जिनके सपनों में जान होती है. पंखों से कुछ नहीं होता, हौसलों में उड़ान होती है. Thank you.
Thank you, sir. Very nice talk. Thanks, Dr. Shukla Sahib. Thank you, Dr. Pranav. Thanks, Dr. Parth Desai. Thanks, Dr. Soma, Madam. And thank you, Dr. Narwani. It is very, very, very useful talk and very, very informative talk for the newcomers. મારે તો એટલું જ કહેવું છે કે જો પ્રેક્ટિસની અંદર પ્રાઇવેટ પ્રેક્ટિસની અંદર સક્સેસફુલ થવું હોય તો આપણા જે લર્નેડ સ્પીકર બોલ્યા લોકેશન્સ ફાઇનાન્સ બ્રાન્ચીસ ઓપરેશનલ એન્ડ માર્કેટિંગ એક શબ્દ અથવા એક લાઈન મારે એવી કહેવી છે સક્સેસ માટે દેટ ઇઝ ધ ડૉક્ટર શુડ academic, social, spiritual and professional. If doctor is full of knowledge, academic, there will be no problem. If it is social, as Dr. Parth Desai says, if you social, there will be no problem in the practice. And ગઈકાલ રાતની સ્પિરિચ્યુઅલની વાત નથી કરતા. હું અત્યારે રિયલી સ્પિરિચ્યુઅલની વાત કરું છું. ઇફ યુ આર સ્પિરિચ્યુઅલ, ગોડ ડેફિનેટલી ગોઈંગ ટુ હેલ્પ અસ ઇન એની વે. એન્ડ લાસ્ટ ઇઝ ઓટોમેટિક વેલકમ, દેટ ઇઝ ધ પ્રોફેશનલ. જેટલું આપણા નસીબમાં હશે, જેટલું આપણને કમ્ફર્ટ જોતું હશે, એટલું ઈશ્વર આપણને આપવા માટે બંધાયેલો છે. તો થેન્ક યુ વેરી મચ. ધીસ અવર કોન્ફરન્સ, ધીસ ઇઝ ધ થેન્ક યુ વેરી મચ સ્પીકર. And again, I am very much thankful to all organizers કે મને અને ડૉક્ટર બ્રાઉને મને એક ઓપોર્ચ્યુનિટી આપી અને છેલ્લે મને મારા બોટમ ઓફ ધ હાર્ટમાંથી જે મને મેસેજ આપવાનું જે ઓપોર્ચ્યુનિટી આપી, એ અગેન થેન્ક યુ વેરી મચ. થેન્ક્સ અ લોટ્સ.
Thank you, sir. Please felicitate our speaker and panelists. I request Dr. Vipul Sarvaiya and Dr. Sugnesh Parmar to felicitate chairpersons. Dr. Vipul Sarvaiya, Dr. Sugnesh Parmar. I request Dr. Dhaval to felicitate chairpersons.
So just before moving to the next session, I would like to say it's a humble request that we are running late of time. So chairperson, it's my humble request to maintain the time frame. Now moving on to next session, that is post-MI ventricular septal rupture. I would like to call upon stage the chairperson, Dr. Kishore Bhai Sheth and Dr. Vipul Bhai Parekh, to please come on the dais. Dr. Kishore Sheth is a senior physician practicing in Bhavnagar since 1992. He has worked in Sterling Hospital for 5 years. His main area of interest are cardiometabolic and infectious disease. Dr. Vipul Parekh is also a practicing physician, consultant in critical care, working in Sri Bajrang Das Bapa Arogya Dham Bhavnagar. His area of interest is nutrition and palliative care. Now I request Chairperson, sir, to introduce our next speaker.
Hello. Next speaker is Dr. Rajiv Vasishtha. He is MCH, DNB, MNMS. He had very bright academic career. He was gold medalist in first MBBS and final MBBS examination. Right now he is head of the Department of the Cardiothoracic Surgery at HCG Hospital, Bhavnagar. Prior to that, he was head of the CTVS units at Medanta SN Hospital and Jan Seva Hospital at Sri Ganganagar, Rajasthan. He had worked at BM Birla Heart Research Center post MCH, associated with Fortis Hospital, Mohali since 2008. Academically active involvement, the teaching curriculum of DNB CTVS at Fortis, and he had started the pediatric cardiac surgery program at Fortis Hospital, Amritsar. Over to you, sir. Please welcome.
Thank you. Thank you. Thank you, sir, for the nice introduction. A very good morning to everyone, my seniors, colleagues, and also thanks to the organizing committee, GMACON 2023. The topic of my presentation is ventricular septal rupture, post-MI. Ventricular septal rupture tends to remain a dreaded mechanical complication in post-MI patients, especially a transmural ST-elevated myocardial infarction. The incidence reported is anywhere between 1 to 2%, though in the post-fibrinolytic or reperfusion era, this incidence has come down to as low as 0.2 to 0.4%. However, this pathology is one pathology which is dreaded by most surgeons as well as cardiologists. There is a high mortality, which is despite various improvements in therapy, and 30-day mortality still is around 74% with 1 year mortality of around 78%. I think, is this working? Okay. Incidence, as I said, is declining due to earlier restoration of flow. This is because it tends to prevent a transmural myocardial infarction and more aggressive blood pressure control in post-MI patients. There is a relative improvement in survival. This is due to earlier diagnosis, earlier flow restoration, and more aggressive surgical intervention. As far as predictors of this VSR are concerned, age, whether it is an advantage or not, is still debatable. It is, however, true that advanced age is a poor prognostic indicator as far as VSR is concerned. However, in patients who have had long-standing diabetes, or patients with chronic smokers, or even patients with chronic stable angina, tend to have a lesser incidence of post-MI VSR. This could in turn be because of a sort of preconditioning or pre-ischemic conditioning of the myocardium. Anterior location of the infarction is more common, and ladies, please beware, female genders are more prone and the prognosis is poorer. This pathology has a typical bimodal mode of presentation. The presentation could be anywhere from few hours of myocardial infarction to a few weeks, though the range is, commonly it is from 1 to 4 days. The time course, however, may be accelerated by thrombolysis, and this is possibly related to intramyocardial hemorrhage. As far as coronary anatomy and VSR is concerned, we find that most post-MI VSRs are associated with 100% occlusion of the infarct-related territory and the territory or the artery which has not been collateralized. As far as anatomy and pathogenesis is concerned, the VSRs are commonly classified as either simple or complex types. These simple are not that simple. However, they are the ones which are associated with anterior wall MI, where the LED is the culprit vessel. And apical VSRs are the ones which we still believe are somewhat simple varieties. Then we have the more complex types, where a serpentigenous dissection tract, which is actually remote from the primary VSR, is present, and this is more so in posterior basal VSRs, that is related to the inferior wall MI. As I said, pathogenesis is concerned, ischemia leading to hyaline degeneration, fragmentation, leukocytic and neutrophilic infiltration with enzymatic degeneration of the area, leading to fissure formation and full blowout septal rupture. As far as hemodynamics is concerned, these hemodynamics means most of the clinical features are because of the acute hemodynamic changes that take place following a VSR. There is acute left to right shunt, decreased cardiac output, acute rise of pulmonary blood flow with increase in pulmonary capillary wedge pressure, and high LV afterload due to peripheral vasoconstriction. So what really happens is the high pressure, high volume chamber of the left ventricle, because of the VSR, there is a left to right shunt leading to right ventricular increase in volume overload as well as pressure overload. This in turn leads to high pulmonary blood flow and secondarily increase in blood return to the left side of the heart, and for the left heart secondary failing. The concomitant problem is the peripheral vasoconstriction with increased afterload that tends to have a deleterious effect on the myocardium. So any condition or any therapy which tends to decrease this peripheral vasoconstriction and bring about a reduction in afterload would help. This requires a judicious titration of both inotropes as well as vasodilators when the patient comes to us. Clinical features, again characterized by chest pain, shortness of breath, hypotension, features which are concomitant with acute MI. However, physical findings are more important, and in such scenario, the best friend is the humble stethoscope, which is not an humble anymore. Here, once you put a stethoscope on the anterior chest wall precordium, there is harsh holosystolic murmur, and even a thrill may be palpable in the parasternal region. There could be associated loud second heart sound and patient may present in pulmonary edema or even in cardiogenic shock. As far as diagnostics are concerned, electrocardiogram or ECG shows features of STEMI or ST elevated MI, anterior wall or inferior wall with certain conduction abnormalities. However, transthoracic echocardiography and color flow Doppler remains the modality of choice as far as investigation is concerned. This is 100% sensitive and specific in not only finding the location and the size of the VSR, but also in differentiating VSR from an acute MR. The million-dollar question is the proper timing of intervention, whether to go in early or late. In my first slide, there was a mention of a point that early surgical correction is considered as a gold standard. However, this is not so simple because every patient needs to be individualized. And as you can see, this is a nice slide which I found, where it is not only balancing once in between early, late, but rebalancing of this patient. That is, continuous assessment of the patient is required. And we have to find whether the patient, because here the question of not only correcting the surgical VSR, but also avoiding the mortality comes into the picture. The challenges which remain are the friable tissue, which don't hold the suture very well. And I believe, as far as a cardiac surgeon is concerned, this is a nightmare situation. Basal septal VSRs or following inferior wall MI are more dangerous variety. They are more serpiginous, gives us a false idea of a small fissure. However, because of the trabeculations which tend to somehow give us a false reading, we find that these VSRs are generally large VSRs, at times even involving the free wall. And as far as timing is concerned, this is one slide which I found very interesting, which was presented in Journal of American Cardiology. Here we find that if nothing is done following acute MI with VSR, survival or death at 30-day interval is close to 90%. Even with surgical intervention, if it is done within the first 24 hours, the results are quite dismal, with mortality of as high as 60%. However, if we can buy time and the patient gives us the time to go in for surgery after a week or 7-day period, then we find that the mortality can be reduced by as high as 50%. Water. So what is a more practical approach? The more practical approach is when a patient comes to us, need to see whether the patient is hemodynamically stable or unstable. In a hemodynamically stable patient with a large VSR, sometimes close monitoring and mechanical circulatory support in the form of IABP or even ECMO where available is a nice or is a better initial modality. If it is a small post-MI VSR, then we can go in for conservative management for initial period of time, get the patient more stabilized, allow the scar to mature, and then go in for surgery. Percutaneous closure, these are the patients in certain cases where the anatomy is favorable and the patient is surgically not a very good candidate. Then as I said, delay surgery, good outcome if the patient is a good surgical candidate. However, what needs to be done in a patient who is hemodynamically unstable? Because this is usually how most of the patients tend to present. We can go in for urgent surgery, again explaining to the patients, the relatives, what are the mortality risks and and survivability after explaining it fully. Or we can go in for mechanical circulatory support in the form of IABP, ECMO, then delay surgery. Or we can go in for percutaneous closure. For this, a complete heart team approach is very much needed, where both the cardiological friends and the cardiac surgeon need to work in tandem and close association. As far as surgical repair is concerned, there is a traditional repair where infarctectomy plus patch closure of the infarct is done. And if the defect is small, we can go in for direct suture. Then there is a David repair, which is basically a infarct exclusion technique. I will not go into the details of it. But the problem or the Achilles heel in all these situations is the ventriculotomy. Somehow or the other, if we can avoid this ventriculotomy, it would help. But this is not so. This I can play? It's already on. For example, this is a patient presented with apical VSR. After cardiopulmonary arrest, the ventriculotomy is done, the apical VSR or the ventricular septal defect is judged. Whatever, at times what is announced or what is diagnosed as a small VSR tends to be a moderate to large size one under cardioplegic arrested heart. Here my cardiotomy sucker is...
yes, okay, okay. You can see the VSD now. My cardiotomy sucker is into the VSD. ये फड़ी दोनों VSD detector फड़ी.
So even I was surprised because VSRs tend to present as surprise on the table.
moderate size VSD. And my cariotomy is right now into the VSD. Oh, this is a big size.
So from the moderate size, it turned out to be a big size VSR.
Thank you.
So, as I said, the Achilles heel is the ventriculotomy. For a 1 to 2 centimeter VSR, the ventriculotomy incision could be anywhere between 5 to 6 centimeters. And then closing this infarcted myocardium is again a hell of a problem. So if an approach could be made where this ventriculotomy could be avoided is something that we need to do. Repair of defect through the right atrial approach, especially in post-infarct VSR, which is posterior basally located, or inferior infarct, can be tried, and this technique, as I said, would avoid an LV incision. However, the experience with this procedure is limited. I happened to present a case at International Coronary Conference in Delhi in a right atrial approach of a posterior basal infarct. I'll be presenting it there in a few moments. This was a 78-year-old man with trochanteric fracture and moderate size VSD. He was referred to us from a local hospital for further management with, again, typical primary history, shortness of breath, profuse sweating, and actually a fall 4 days prior. The question is whether this fall and acute hypotension which has occurred was the reason why the VSR had taken place. Patient went in for trochanteric fracture repair. In the pre-surgical workup, the ECG was abnormal, and the gentleman, our anesthesiologist friend, found that there was something going on, some adventitious sounds were heard, and the patient was referred to us. This patient at the time of presentation was disoriented state with dyselectrolytemia, raised level of cardiac enzymes, and TLC. Clinical features were inferior wall MI, typical with sinus rhythm, however having left bundle branch block pattern. Review echocardiography was done with heart function of around 40 to 45% and akinetic part of the inferior posterior wall and part of the apex. VSR was seen, posterior inferior septum, and there was trivial MR. This is the transesophageal echocardiography picture which was taken at the time of operation theater. As we can see, this is the defect, posterior basal. This is the LV, this is the RV, LA, RA, and the color flow can be seen where there is a left to right shunt through this VSR. So after cardiopulmonary bypass and cardioplegic arrest, the RA was opened and the VSR was defined through the tricuspid valve. We found a moderate size VSR and the margins were clearly defined. In this case, the patient was lucky, and I would say that even the surgeon was lucky because the patient was already about 10 to 12 days post-MI. So somehow the margins had been more clearly defined and we were able to take adequate sutures. Here we see, this is the RA opened, tricuspid valve. Through the tricuspid valve, my cardiotomy sucker is into the VSR. So an adequate sized Dacron patch was used with interrupted pleated sutures, tricuspid, and after closure, tricuspid valve was checked for any appreciable regurgitation. We were able to put in 2 vein grafts on the LAD and the PDA. This again would not have been possible if ventriculotomy was the primary approach. What has been done is, because of this, this is the LAD, this is the vein graft to the LAD, and this is a vein graft which is going to the posterior descending artery posteriorly. In anterior or the apical type of a VSR, a newer technique has been tried in conjunction with what our cardiological friends are doing as far as device is concerned. That is an implanter device. So what is done is a transaortic and transatrial approach is sometimes taken. Through the transaortic, we put a patch, and that patch is sandwiched with another patch which is put through the RA. So the whole idea is somehow to avoid a ventriculotomy in these patients. This is the post repair status of this patient. Here is the patch after the correction, and as we can see, there is hardly any shunt or no shunt. So the post-operative recovery, patient was shifted on IIBP with moderate inotropic support, extubated the next day, and over the next 2 days, we were able to take out the IIBP and the supports. This patient who is not able to walk, having a trochanteric fracture, thankful to God and to our team, we were able to send this patient back. Thank you.
Thank you, Rajiv bhai, for such wonderful talk. Now, most of the time, this VSD happens to some primary centers. And many a time we need to transfer this kind of patients to a facility where CTVS backup is there. Now, that is the part where rest of the specialties comes into the picture. Then what care should we take in the terms of hemodynamics and choosing a vasopressors? Because we need to transfer patients, so we cannot opt for option of IABP.
Sir, in that case, as I said, judicious titration of vasodilators and inotropes is very important.
Which vasodilator?
I would go in for, say, a dobutamine along with a simple noradrenaline, or even vasopressin. Vasopressin is not a drug which has to be neglected, because as far as transfer is concerned, at many times we find that even in the ambulance care, IABP support or mechanical circulatory support is not a possibility. However, if the patient is in cardiogenic shock and not able to make to the tertiary care center, then we need to really worry whether we can put this patient in some sort of conservative treatment so as to stabilize the patient to some extent before 2 to 3 hours journey can be undertaken. But definitely this is one scenario which needs to be avoided. If a patient comes at the peripheral center following a large STEMI, what we need to do is check or put in a stethoscope. If we find that any adventitious sound is there, then avoid giving fibrinolytic therapy, thrombolizing this patient, because that is going to worsen the condition. In that case, try to immediately shift or transfer the patient to a higher center.
And like while hemodynamically unstable patient who needs to be transferred, like intubating a patient and giving high PEEP, will it help to reduce left to right shunt?
No. That will again, because all the patients do not behave in a similar pattern. And high PEEP in turn would lead to compromising the acute setting of this hemodynamic changes. Because it is not a chronic condition that the patient is coming to. Because of this acute nature, PEEP has to be judged. As I said, this is one condition where every hourly monitoring of this patient is needed. And no one treatment can be done leaving the patient off for a few hours also.
Any questions from audience?
Now I'd request the chairperson, sir, to please honor the speaker with the memento. I request Dr. Vipul Sarvaiya, past IMA president, to honor the chairpersons with the memento.
Thank you, sir. Thank you, sir.
I know it's pre-lunch hours, there will be a bit of hypoglycemia, but a few
Thank you,
claps
Dr.
are most
Rajiv.
welcome. Thank you, chairpersons and speaker, sir, for that wonderful interactive session.